start the game again. Hello, and I'd like to welcome everybody to MedEd Day. On behalf of the Academy of Master Educators, I'd like to welcome you to our 5th MedEd Day and our first virtual MedEd Day. So fingers crossed, hopefully everything will come off without a glitch. To begin, I'd like to thank Holly Yolanowitz, who has been our administrative support person throughout the process, and to our planning committee. The planning committee members consisted of Gabby Gossman, Carla Spagnoletti, Ankur Doshi, Cynthia Lance-Jones, Peter Drain, and Peter Feldkamp. Next, a couple of housekeeping measures. Some upcoming events. The Academy of Master Educators will be issuing a call for new members this fall. You can nominate yourself or a colleague, so just watch for details on the AME website. And also we'll be developing bylaws this year, and those will be distributed for comment and approval. Next, I'd like to review our agenda for today. We have a full schedule of events. First, I wanted to mention that we have, in lieu of actual posters that are printed, we will be having e-posters that are pre-recorded and posted online, and they're available. We'll begin with our keynote speaker from noon until 1 p.m., followed by our first workshop at 1:15, which is using social media in academic medicine. And that'll be presented by Mike Simonson, Casey McQuaid, and Amr Kohli. Our second workshop will be Beyond Zoom, Effective Use of Remote Learning Technology by J.B. McGee, and that will be from 2:30 to 3:30. So now let me introduce our keynote speaker, Dr. William Cutrer, MD, MED. Dr. Cutrer received his MD from the University of Kentucky College of Medicine. He did a pediatrics residency, chief residency, and pediatric critical care fellowship at Baylor College of Medicine and the Texas Children's Hospital. He then received his Master's of Education from the University of Cincinnati. Currently, Dr. Cutrer is Associate Dean for Undergraduate Medical Education and Associate Professor of Pediatrics and Critical Care Medicine at Vanderbilt University School of Medicine and the Monroe Carroll Jr. Children's Hospital at Vanderbilt. Some things that Dr. Cutrer has been involved in nationally: he led the AMA's Accelerating Change in Medical Education Initiative, Master Adaptive Learner Working Group. He leads Vanderbilt's core team that is participating in the AAMC project core EPAs for entering residency. He is co-PI on a project selected for the AMA's Reimagining Residency Initiative. And Dr. Cutrer is also part of the Kern National Network for Caring and Character in Medicine. So you can see he's involved in medical education at a variety of levels, undergraduate, residency, nationally and locally. Dr. Cutrer is interested in helping students to learn more effectively in the workplace. He's published and presented extensively in the field. In particular, I'd like to draw your attention to a few of his publications that caught my attention. He wrote Fostering the Development of Master Adaptive Learners, a Conceptual Model. This was in Academic Medicine 2017. It was a roadmap to providing learners with strategies to learn in healthcare environments and to manage change, emphasizing a metacognitive approach based on self-regulation. This year he published a paper in Medical Teacher that used 2 validated scales to measure students' competency in EPAs in clinical settings and examine whether the scales added to each other. His talk today is targeting adaptive expertise theory and strategies to guide medical learners. So let's welcome Dr. Cutrer.
Hello. Thank you so much for being here with us today. I'm really excited to spend this time with you, even though I'm not able to be there physically in person. I really hope we're able to dive into what I think is a really exciting topic and really applicable to the current context that we're living in right now. And so I want to think with you about targeting adaptive expertise, theory and strategies to guide healthcare learners. And so I hope that we can dive into this topic together today and have a little bit of fun while we're doing it. I don't have any disclosures, but I do want to let you know that some of the work that I'll talk about came from the AMA's Accelerating Change in Medical Education Consortium Initiative, and part of that funding for my time during that came from this. I will mention a book that is put out by the AMA that I helped edit. I don't receive any royalties from it, so I just provide it as a resource. All right, I do have one other disclosure that I want to make up front. Clinically, I'm a pediatric ICU doctor. So I work at the Children's Hospital. I work in an ICU that has patients that look like the one here on the lower right, multiple technologies, a lot that's involved with that. And so my lens of thinking about problems is often framed, whether I know it or not, by that pediatric intensivist lens. And so I just put that out there so that you know where I'm coming from. I will try for my stories to not all be pediatrics related or even medical education related, but to try to cover the gamut. But really hope to dive into this. So if I were in person, I would actually hand you a note card to use during the session. But since we're not, I'll ask you to either grab a note card if you have one handy or to grab a scrap piece of paper. Either will work. We'll circle back to that in just a little bit. All right, my students would laugh if they were here now because almost every talk I give has a slide like this at the beginning. What is the why? Why are we here? Why now? Why this session? And I hope that over the next few minutes, I can actually convince you of the why I think adaptive expertise is important, and then how we help develop it in ourselves and in our trainees. But hopefully we'll be able to answer that by the end as well. By the end of the session, I would love for you to be able to do each of these. Compare and contrast routine and adaptive expertise within the medical context. Describe the rationale for adaptive expertise within the healthcare and why that's important. And then really discuss some skills and the process for learning that foster the development of that adaptive expertise. All right, so here's the roadmap. Here's where we're going to go over the next little while. We'll save some time at the end for us to do some question and answer. We're going to start with why expertise is needed. Then we're going to dive into what expertise is, and then we'll finish up with how do we actually develop the expertise. And again, I hope each of these components are fun, engaging, exciting for you, and really allow you to wrestle with what's going on in your current context, with your trainees, with yourself and your practice, and to really understand it. So let's start with why. Why is expertise needed? So I want to talk about two gaps. And the first gap is the one that you see here. This is a gap between what we do and what is known. I would argue this gap is actually pretty big, and it's bigger than we think it is. So in 2001, the IOM Institute of Medicine came out with a report called Crossing the Quality Chasm. And they described a gap between medical advances and the medical care that was actually being provided. In that, they quoted over 400 quality indicators, a study that looked at that, over 6,000, almost 7,000 patients from a dozen metropolitan areas, and 45% of them were not receiving recommended care. Now you can see this is an old study, but unfortunately we haven't gotten a lot better. There's an average lag time of 17 years to translate discovery into practice. That's 17 years of your mom, your grandmother, your child, yourself, receiving the wrong therapy for a condition that is known and we already have good evidence. That gap between what is actually done and what we know, the royal we of healthcare and of medicine, what's known in the literature, that should be disturbing to all of us, that the wrong therapies are being put out there. So I also want to recognize that medicine today is changing. If you look at a lot of different publications, there's a lot of articles, and you'll even see the dates if you squint carefully. These are not new. These are actually almost 10 years old now, some of these articles. Rapidly changing environment, quickly changing. There's rapid changes. The pace of things have changed. And I would argue within the last 6 to 8 months, things have probably changed for you even more rapid than before. As we think about the changing practice context, these are some of the things that have been described in the literature, although you'll also notice that this paper is from 94. So they recognize a rapidly changing, continually changing practice even then, and I've actually read pieces from the early 1900s, even the late 1800s, that talk about how quickly medicine was changing. It has been a consistent problem, although it feels like the pace is really escalating on us. I really want to focus down here at the bottom, though, talking about new diseases, re-emergence of old diseases, but at the bottom talking about medical science and how quickly our knowledge base is expanding. When I started giving talks like this, the medical literature was doubling every 5 to 7 years. When I Googled it earlier this year, when I was giving a similar talk to our students, the medical literature is now doubling every 73 days. 73 days. That's crazy. That's a lot for us to know. I imagine many of you have probably heard of UpToDate and potentially even use it. This is the editor-in-chief of UpToDate saying that the physician's conundrum is too much information, too little time. That's a problem. When one of the major resources that many of us as physicians use is saying there's too much information and too little time. There are others that have written about this. This is an old slide, but I keep it in here because I think it's actually really impactful. It came out around 2011 or 2012, and it said by 2020, we're there now, we as doctors, we as the healthcare team will face 200 times more medical data than we can actually incorporate to use for medical decision making. That feels overwhelming and not all that tangible, but let's move to the upper right there. Talked about, again, the medical literature doubling every 5 years. Nope, that's every 73 days now. But actually the one that on this slide that worries me the most or gives me the most concern is that lower right. 81% of physicians that were surveyed said they couldn't spare 5 hours a month to stay current with literature. That's a little over an hour a week to stay current. And so I think that's at least part of why we have that 17-year gap that I mentioned earlier. This is a problem. How many of you have felt like this before? I love this. And we'll have a test on all of this on Friday. Any questions? Now, I have to be honest, there is something that's actually a little bit calming about this board. As overwhelming as it is, there are edges to the board. It's not changing, unlike our medical context that is constantly evolving, expanding, growing. So our board doesn't have edges, but there will be a test, and it's that patient in front of us every time we interact with them that needs us to do the right therapy for them at the right time. So that gap, that first gap we talked about between what is known in the literature and what we actually do, you actually need routine expertise to address that, to be able to take known solutions and apply them to known problems effectively and efficiently. That's really, really important. But I also want to talk about a second gap. This is a gap between what is known in the literature and solutions to new and novel challenges. That's a second gap, and it's really important to be able to address that gap also. So as physicians, we face novel challenges, and it's not just physicians. This is nurses, therapists, social workers, all of us as the healthcare team. Most of my time is spent training medical students, so I often think about the physician context, but it's true across our healthcare context. Thinking about drug-resistant, antibiotic drug-resistant infections, that's been a problem. Obesity is a huge public health crisis that is continuing to get worse. What about physician burnout? This is a huge crisis that doesn't yet have a known solution that we can consistently apply to address. It is a novel challenge that is just getting worse. I would imagine that this graphic probably means something to a few of us with a certain little novel challenge that we've been facing over the last few months. Not just how do we take care of our patients with coronavirus or COVID-19, how do we manage the society, things like flattening the curve, social distancing, masking, but also how do we as medical educators adapt and adjust the way we train our students, the way we train our residents, our nurses. How do we do that in a way that's so different and feels so overwhelming compared to where we were a few months ago? That's a new and novel challenge that needs what I would argue something different. This is a quote that I really like. The imperative for developing adaptive expertise in health professions education is growing as the workplace increasingly causes clinicians to confront new challenges. So Maria Malopoulos and Nikki Woods would argue that adaptive expertise is what is needed to confront those new and novel challenges. And whether that's the outpatient setting, an ER or operating room, or the ICU like I practice in, that adaptive expertise is needed. And so here, that routine expertise addresses that first gap. Adaptive expertise is what is needed to address the second gap between what is known and those new novel challenges. These are not either or. They're actually complementary expertise, and we need both as healthcare providers. All right, so a question for you. Does our current system produce this type of doctors or healthcare providers? Think for a minute. So everybody who's not a practicing physician, so any trainees and nurses, you guys are off the hook for the next few slides. This is data around those of us that are practicing physicians. Do we learn and develop this type of expertise? So this is a really good paper, and I would point all of you toward it, from Glenn Regehr and Maria Malopoulos, around 4 assumptions around practicing physicians. So the first assumption is that we as practicing physicians, and I say we because I am one, I still practice clinically in the pediatric ICU as I mentioned, that we will naturally reflect on our performance for the purpose of highlighting our own weaknesses and gaps. Right? That's good. The problem is we don't actually do this. We don't naturally reflect, and there's really good evidence, unfortunately, that we will discount things that don't fit in with our self-image, or if we think of ourselves as being brilliant and smart and great doctors, anything that says maybe that's not the case, we're going to discount it. But let's say for the sake, I'm sure that's not you or me, maybe it is, I don't know. I don't know you yet. But let's say for the sake of argument that we do actually try to look for our identity, or look for our weaknesses. The second assumption is that if you try to look, you actually can identify those weaknesses when you're looking for them. This would be great, right? It would be lovely if it were true. Unfortunately, it's not. We as humans are horrible self-assessors, and there's really good information and data around that. And so if I were in person with you, I'd ask you for a show of hands, how many of you are an above average driver? I'd wait for it to go. When I've done this in rooms, the vast majority go up. I've done it with a room full of surgeons, and every hand went up. So there's either something inherently about being a surgeon and their training that makes you a better driver, or again, we as humans are not good self-assessors. So that we think we're the muscle man, but really we're the nerd. It's okay, embrace that inner nerd. We need to know where those weaknesses are so that we can address them. But let's say for the sake of argument, we do try to look for our weaknesses. We're actually able to identify them. The third assumption is that we will then try to address those weaknesses with learning. We get this one right. No, we don't, because learning in areas of weakness is difficult. And we often will gravitate towards relearning things that are easy or fun. We get that immediate reward, rather than focusing on areas that we need to improve. We focus on areas of strength. I don't know if there's any weightlifters in the crowd, but this is the equivalent of if you have a well-established upper body, continuing to do that while skipping the leg work. All right, but let's say for the sake of argument, we do try to find our weaknesses. We're actually able to identify them. We do try to address them with learning. The fourth assumption is that we actually effectively incorporate that new knowledge into our practice. Yeah, we don't do this well either as practicing physicians, unfortunately. So we seldom use that new knowledge, incorporating it into our practice. This is one example of a study that they cited that looked at CME type events. Of those that attended, only 64% planned to change anything, and of that 64%, less than half of them actually made those changes, which is bad because you actually end off worse than before because you're a little bit more familiar with the idea or the topic, but you haven't actually changed your practice. That's pretty disheartening for those of us that are practicing physicians. And this quote at the top, I think, really accurately describes why that's the case. Much of an experienced practitioner's daily practice has less to do with solving problems than remembering solutions. So that's that routine expertise. We're taking that known solution off the shelf, applying it to the problem. So they've actually done studies, and you can predict how a given physician will take care of diabetes or hypertension based on 2 things. What year they graduated residency and where they did their residency training. That's disheartening. That means people do not continue to learn and grow in a lifelong fashion, but they practice the way they did in training. That leads to the gap that we talked about before. The 17-year gap is because you need to train a whole new generation that knows the better, correct way to do it. So again, we need both the routine expertise to take known solutions and apply them to known problems, but we also need adaptive expertise to create solutions to those new and novel challenges. All right, so hopefully I've convinced you that the why is important, but now let's talk a little bit about what. What is expertise? So I want you to pause for a minute, grab that scrap of paper or that note card. Write down a question or two if you have them around what is adaptive expertise. I've alluded to it earlier and told you that it's needed to solve new and novel challenges, but I haven't told you what detail that is yet. All right, let's move on. Any movie fans out there? Yeah, there's a lot of us that love movies. Anybody seen Apollo 13? Again, I did part of my training in Houston, so everybody in Houston has seen this. That famous line, "Houston, we have a problem." So think to a minute, do you remember what happened in Apollo 13? There's the really pivotal scene where you've got this character saying, we've never lost an American in space, and we're not going to do it on my watch. Failure is not an option. They were faced with a challenge. It had to do with the carbon dioxide clearance system and the air intake manifolds, but they functionally had to get the square thing to fit into the round hole using nothing but what was on the table. So they had never had to solve that problem before. It was a new novel challenge. They had expertise, but not to solve that problem. So what they needed was to be able to take what they knew, learn new things, and solve the problem based with the materials that they had available. And they were able to do it. It's a great movie. I highly recommend it. How about this one? A little bit more modern version of space exploration. It's The Martian. So Matt Damon fans out there, he has a really fun movie where he gets stranded on Mars and has to figure out how to survive. He's a botanist, so he figures out how to grow food and things. I won't ruin it, but it's a really good movie. And I would argue what he is doing all day, every day is adaptive expertise. Taking what he knows about plants and growing things and survival skills and applying them to that new context of Mars. All right, any TV fans? How about this show, Mythbusters? I would argue Mythbusters demonstrates adaptive expertise all episode, every episode. So for those of you that haven't seen it, they take a myth that is out there, oftentimes on the internet, and they try to prove or disprove it, and it often involves blowing things up. It's great. For those of you that have seen the show, does their first attempt to solve the problem ever work? No, it doesn't. And so the rest of the show is spent iterating and taking what they know about explosives, about physics, about different areas of science, and applying that to solve the myth, to prove or to disprove it. That's adaptive expertise, and it's fun to watch while we get to participate. So to dive a little more deeply into the literature and what it says around adaptive expertise, it really is that ability to function efficiently on everyday tasks. That's the routine expertise, but it's also then the ability to create solutions to those workplace challenges. So it involves an individual using these skills, but the first important step is to recognize that the routine approach won't work in this new context, in the place that you are with the challenge you're facing. And the adaptive expertise allows the individual to reframe the problem in a way that allows her to explore new concepts, i.e. learning, and to invent new solutions, innovation. And so it's that learning and innovation partnership that really allows adaptive expertise to thrive. Now, you have to learn in a way that sets you up to develop and demonstrate that adaptive expertise. So the literature talks about this being a product of a learned skill set, characterized by habits of mind that develop over time with practice. We can practice it. So these are characterized by people that have better metacognitive skills. They're being more flexible, not physically, but mentally. Ability to innovate, continuous learning, seeking out challenges, creativity. A lot of the things that we love to see in our learners and love to interact with, hopefully we have these ourselves. But these are the things, and so this idea of it being a learned skill set is why we think it's so important with my students here at Vanderbilt to begin this process of teaching that skill set or developing those habits of mind and providing opportunities for practice early on, including year one of med school and doing it throughout, and then continuing to work with them as trainees and ultimately faculty. All right, so this is actually a leadership model that we use with our students, and I want to just compare and contrast a little bit this model of leadership with adaptive expertise. So the model of leadership is kind of starting with self-leadership, moving to leadership of others and teams, and then ultimately the system or the organization. And I would argue that adaptive expertise has a similar parallel process where adaptive expertise in medicine can be applied to an individual patient, to a panel of patients or a unit or clinic, and ultimately to the larger population or society. And so I just want to share a couple of quick examples of what that could look like. So as I think about individual patients, again, I'm a pediatrician, so I think about acute otitis media or an ear infection. We often use the pink medicine or amoxicillin, but it has to be refrigerated. So what if the family is about to go traveling and doesn't have access to refrigeration? I can't take my known solution of amoxicillin for this ear infection and give it to them because it won't work. I need to come up with a new solution. Now, luckily, there are others that have come up with that solution, so I can go and ask, or I can do that research. That's great. I've also had a patient who needed home BiPAP for respiratory support, and it got cut off here, but it says without power. So how do you send a patient home who needs a medical therapy that requires power to a house that doesn't have power? This has required some creative problem solving. I would argue this is one of the places where our social workers are absolutely amazing. They solve problems better than anyone I've seen using that adaptive expertise that they have developed. So I'm thinking about adaptive expertise applied to a panel of patients. Anybody know what this is? Yeah, it's a central line. So if you flash back 15 years ago, 20 years ago, we were having a lot of problems with central lines becoming infected. This, again, I'm a pediatrician. These are some of the places that we can put these central venous catheters in: the jugular vein, the subclavian vein, the femoral vein, etc. The catheter goes in, but then is prone to both infection and clot. And so there's been a lot of work done to figure out how do we keep that from happening. And so for those of you that are in the ICU setting or in the hospital setting, you've probably been aware of some of this work. We've taken what was a novel challenge 15 or 20 years ago, we've learned a lot about it, and we've actually routinized that information. So now we have central line bundles. So I don't have to solve this new challenge every time. I can go right to the bundle and it tells me what to do. So it has become routine for me now. I take that known solution and apply it to the problem now, as opposed to it being a new and novel challenge. But it started as a novel challenge as we were starting to use more and more central lines. Now, as we think about the population or the society at large, how might we apply adaptive expertise? There are a lot of different problems that we could use. This is one, medical student mistreatment, that's near and dear to my heart. How do we advocate for our students in a way that addresses that better? There's no known solution for this. There's a lot of things being tried around the country and even around the world, but there's not a one magic solution that everybody knows is just the right one to go and do it. So this is a new and novel challenge that I argue will require adaptive expertise. All right, just to re-highlight these same issues, again, adaptive expertise says, the routine approach won't work right here, so I need to flip. I need to reframe the problem, and that will allow me to explore new concepts and invent new solutions. All right, so let's get to the meat of how do we actually do this for ourselves and for our trainees. All right, two quick book recommendations that I have found really helpful. The first is The Obstacle is the Way. Ryan Holiday writes really well about Marcus Aurelius and some of the old-time philosophers, and there's a great example about what stands in the way becomes the way. And talking about taking a challenge, taking something that feels like an immovable obstacle and actually using that as the way forward. I'll tell you, I've actually given this book to a few of my staff and faculty to thank them for all of their help with adapting our curriculum to the coronavirus and things we've had to change. They took what was a huge obstacle, i.e. moving to virtual learning immediately, i.e. today we have to flip to being fully virtual. Luckily this was a few months ago and we had the time to do it, and now we're back to learning in person, but there was a lot of adaptation. We had never done that before, and so that was adaptive expertise. And so this book is a great way to dive into some of that. And then The Smart Thinking is written by Art Markham, who's a PhD professor at UT Austin. And he talks about developing smart habits, recognizing high quality knowledge, and then being able to apply that knowledge to goals. And so it's a helpful framework. All right, so I want to spend a little bit of time talking about this work. It's the idea of a master adaptive learner. So it comes out of this original paper from a group of us within the AMA's Accelerating Change in Medical Education Consortium to describe a new type of metacognitive learning that really addresses that. I did mention that there's a book that's come out. Again, I don't get any royalties, but it is a really helpful resource where we brought together a lot of really talented, great, deep thinkers to help write chapters for us. All right, so this is the model, and I'd actually just want to pause there and give you a minute to look at the different pieces, and I'll walk through and highlight a few of the things. And the reason for this is we think that this type of approach to learning that is based on the educational literature, both the general education literature and the medical education literature. There's really not a ton of new ideas in this model, but it pulls together a lot of different areas of the literature. This type of learning will lead to that adaptive expertise that we are hoping for within our learners. And so I want to take a few minutes to point out different components of this model. So the first, you can see the gears within the head over here. Around that are 4 skills. The first is self-monitoring. This is absolutely critical. Our ability to notice our own actions, to be curious. Ooh, I'm a little bit revved up right now. Why am I anxious? Why am I feeling sad? Why am I angry? Recognize that. Why am I feeling like I don't know what's going on? Oh, I don't know what's going on. That's good to recognize that. Next, metacognition, the ability to set goals, to plan an approach, to monitor that progress, and then to make adjustments as we go. This one is absolutely critical. And again, I think metacognitive skills are incredibly important to develop in our trainees, and so we start even in year 1 with our students thinking about this. Reflection, the ability to think and process information before, during, or after a situation to pull out those nuggets of learning and really allow them to take hold. And then critical thinking is that higher order set of cognitive skills, conceptualization, analysis, evaluation, and things that allow us to really deliberately think about the way we think. Those are all four important, and they go on throughout this entire process. All right, so I want to pull back to the bigger view, and then I want to focus down here at the bottom. You see what we envision as a rheostat, coaching. So I will not argue that you have to absolutely have a coach to learn, but I will argue, and I think the literature supports, that actually working with a coach can improve learning, both in its efficiency and its efficacy. Any Atul Gawande fans in the group? I really love his writing. I think he does a fabulous job. So this is a piece that he wrote back in 2011, where he poses the question, top athletes and singers have coaches, should you? And so he walks through his own experience as a practicing surgeon. He does endocrine surgery. And he just describes it incredibly well, where he was about 4 or 5 years out in practice, and he felt like his surgical skills and his overall practice was good, but it plateaued. So we brought in a more senior surgeon to observe him in the operating room and to provide him feedback on everything from how he draped the table to the economy of motion, which is something that surgeons, you all know better than I do. You see I have very little economy of motion, but it's something that surgeons value, of not wasting motion, to be very deliberate and intentional. And so this more senior surgeon gave him some very specific targeted feedback. And Gawande goes on to talk about how his practice, his surgical skill improved dramatically, so he continues to work with more senior surgeons to give him that feedback real time in the operating room. The same is true for us. A lot of our leadership colleagues use leadership executive coaches. We've developed a coaching program for our students because we think it's really important to provide that external perspective for them. There's great literature around that. All right. If you noticed on the original diagram, there's also four batteries in the lower right-hand corner. Curiosity, thinking about how do we want our learners to just be driven by wanting to know more. If you think about the learners that you've worked with that you really enjoyed the most, they're probably incredibly curious. They ask great questions. They just want to know more. They want to know why. Think about a toddler. They want to know why. They ask why, over and over. That's a lot of curiosity. Motivation, being more intrinsically motivated than extrinsically motivated. Mindset, having a growth mindset that you can always improve, you can always learn, as opposed to a fixed mindset that you know what you know, challenges are scary and you want to run from them. And then lastly, resilience, or grit, as Angela Duckworth calls it, that ability to persist towards a goal in the face of challenges. I think all four of these are absolutely critical to developing adaptive expertise, and we think they're actually what power this type of learning. All right, so I do want to also highlight that all of this happens within the context of a working learning environment. Now, I can tell you the environment for my pre-clerkship students is very different, right? I can control everything down to the temperature in the room, the lighting, all of that. Now we're 6 feet apart and wearing masks. I wouldn't necessarily have planned that, but it is helpful in keeping them learning in person. The clinical learning environment, however, is very different, right? There's a lot written about the hidden curriculum. There are plenty of things in that curriculum that I would never intentionally put there for my students. I would never have my students see a surgeon getting made fun of by an internist or vice versa. Would never see a patient getting made fun of by a clinical team. Those are not things I would want my students to see. I definitely don't want them to repeat that, but those are things that are in the clinical learning environment. So we have to be aware of the context that this type of learning is happening in. Now we also have to be aware of other things within that context, like grades, residency applications, applications for jobs, and things that also put external motivators or qualifiers on the learning and make it even more difficult. All right, others that can be rapidly changing environment we talked about: lack of time, inter-team dynamics, duty hours, complexity, etc. All right, so I want to take a little bit of time now to dive into the middle, into the meat of this model. You'll see there are 4 phases: planning, learning, assessing, and adjusting. For any of those of you that do quality improvement, this should look pretty familiar. This is very much the same structure as the PDSA cycle, plan, do, study, act, that quality improvement uses to improve care within our healthcare setting. We love that idea of our students doing PDSA cycles of themselves as learners, as practitioners. So starting in the upper right, the planning phase, you can see that there are 3 parts to this. The first is identifying a gap between what is and what could be or should be. So this gap identification step is incredibly important, and we'll talk about it in a minute. Moving from gap identification to selecting one of those for learning, and then searching out resources for learning. I would argue most of students in general, skip this planning phase. They want to jump right into the learning. I've got a few minutes, let's just learn, rather than taking the time to be thoughtful and planning it out. This is one of the ways that we can very much help, especially more junior learners. I don't know if any of you have seen this book, but it's a fabulous book called Being Wrong by Catherine Schultz. She's got a great TED Talk, for those of you that like TED Talks, but she walks through, most of us don't like being wrong. We hate it. We actually want to run away from it. Her argument is, instead of that, we should run towards it, because the places where we are wrong highlight where we can grow and improve, highlight those areas for learning. So thinking about that entry step, identifying the gap, that can be a gap in knowledge, a gap in skills, a gap in attitudes. This is really where we as practicing physicians, and definitely our trainees, have the ability to improve and to grow. That has to then be followed, though, by the selecting opportunity, because I'll be honest, when I work a shift in the pediatric ICU, there's at least one, if not multiple, gaps that I'm able to identify in my own practice. I often don't have time every night to go home and look up all of those, so I have to prioritize which of those opportunities are the most directly important for my patients, and then search out the appropriate learning resources. All right, but after we've done the planning, we can move down to the learning phase and actually engage in that learning. So this is a mixture of finding good, high quality resources and critically appraising them, and using effective learning strategies. Now, I would also argue that the effective learning strategies is one that many of us probably aren't doing. So I'm not going to ask for a show of hands, but think to yourself if this is a strategy you have used. There's really good general education literature and medical education literature about how bad some of these strategies are. Rereading is an absolutely horrible strategy, and I do it all the time. It's bad on three accounts. It's time consuming, it doesn't lead to durable memory, and it gives you that false sense of familiarity, like, oh yeah, I know that topic. That's not good. The rereading is often paired with the highlighting and underlining. Yep, I also do that. And the cramming. So again, think about a lot of our medical students or our healthcare profession students. These are a lot of the strategies that got them successfully into our health profession school, but it won't actually help them learn in a way that leads to adaptive expertise or that leads to lifelong learning. It's studying for a short-term exam, remembering it all, and then letting it fall out. That's not helpful. Make It Stick is a great book for those of you that want a little deeper dive into some of these educational strategies. But the quote that really stuck with me is, learning is deeper and more durable when it's effortful. So if it's easy, you're probably not actually learning, or our students aren't probably actually learning if it's easy. All right, so 3 strategies that we often talk about with our students that I think are really important for you to know about and to consider how to work with your students with, or your trainees or your residents, whoever you might work with. They also work for us as practicing people as well. Knowledge retrieval strategies, spaced repetitious learning, and then concept mapping. So retrieval strategies, things like flashcards, they actually are pretty good because you're using it as a self-quiz or a self-test. There are a lot of other different type of self-assessments out there. Now, I will tell you, this does not work as a standalone only strategy. It's actually really good to help learners know where their areas of strength are. Great, they don't need to study more there. Areas of weakness, good, let's focus a little bit more there. But the students that I have also seen struggle are ones that use this type of strategy only. They really need to think a little bit more broadly about how to incorporate this with other strategies. All right. The next is spaced repetitious learning. And this is a really interesting concept with great educational literature of we start to learn, and the minute we stop, we start to forget. There's some great work on forgetting curves. If you interrupt that forgetting curve with more learning, they continue to learn upwards from that point. The minute they stop learning again, start to forget. If you continue to interrupt that with learning spaced out over time, hence the spaced repetitious learning, the learning overall is markedly improved, and they're able to retain more and understand it. All right, the third strategy is concept mapping. I don't know if any of you are familiar with concept mapping. It's a strategy that's actually really good with some great educational literature also. And so this is a concept map of concept mapping, which is a little bit meta. I totally get it. But the idea of a concept map involves all of the major concepts about a given topic. It forces trainees or individuals to put on paper how they're thinking. So if they're doing this with a coach or a resident or someone they're working with, it actually is really helpful to identify areas where they already know things really well. Great, don't spend your time trying to teach them that. Areas where they might have some misconceptions, okay, let's dive in and talk about that. So it can be very helpful in putting a student's thinking on paper visually to help with themselves, looking for connections, as well as to help others. So this has been shown as a tool over and over to increase meaningful learning compared to rote memorization. It allows the teachers to visualize their learners' understanding, as I mentioned, but it also forces learners to wrestle with content and make decisions about how are things connected, what's important and what's not important. And so it's a really powerful skill. Now, I will tell you, with concept mapping especially, but with the others also, one of the things we often hear from our trainees, but it just takes too long. That's true. It does take longer, but remember the quote about learning being effortful? Yeah, if it's very quick and it doesn't feel hard, you're probably not learning. And so this is taken from the Master Adaptive Learner book, but this idea of the initial investment in learning by doing it a little bit slower, by doing it the hard way, is harder. And the learning in the short term isn't quite as fast, isn't quite as much. But then you reach an inflection point where you have learned it so well that you can integrate it with other concepts, you can include new concepts into it, and it actually is far more impactful in the long run to lead to that adaptive expertise. All right, in thinking about the lower left over here, the assessing phase. And so this is one that's also skipped quite often. Trying out what was learned. Did I learn the right things or not? And so the assessing phase is a combination of two components. It combines informed self-assessment and external feedback. So that informed self-assessment is very different than the self-assessment we talked about before. I'm a good driver. I'm a better driver than you. I'm great at this. It's informed, which means it takes data that's available and uses that to inform the self-assessment. It takes the incorporation of feedback from a 360 evaluation from multiple different data points. Whatever it is that is being used to inform it, it is not simple just thinking and reflecting. It is data-driven, information-informed self-assessment. And then external feedback, that external perspective that comes alongside and says, I understand that you think you do that very well. Let me ask you a question. Or how did you think someone else responded to you in that situation? Again, one of the things I find in that kind of coaching role of external feedback is the power of a really good question. A really good question can absolutely frame the student's thinking on the topic and can help them dive in and really wrestle with, okay, is this actually helpful? Does it really work? And so I will pause there. Okay, lastly, the adjusting phase. Now this is really important. And going back to the CME evidence that we as practicing physicians don't actually change our practice, we as practicing physicians skip this step. This is where we actually incorporate what we've learned into our practice in a way that changes and hopefully improves the care for patients. So at the core, there are a couple of different pieces to incorporating that into practice. We have to decide, is this a new routine solution that I can just apply to known problems? I just didn't know about it before. Great. Apply that to those routine problems. Or is this new novel learning that I need to apply to those novel challenges, new novel situations? Great, let's do that. We also, though, have to think about, does the change have to occur in just me as the practitioner, or does it have to occur and change in others? The minute that you start to involve others, the harder this gets. And so for me, for example, if I have to decide, instead of using antibiotic X, I now have learned that I need to use antibiotic Y, that's a pretty small change. It doesn't impact my identity as a physician. I can do that without a lot of problem. If I were a surgeon in the late 90s or the 90s thinking about how I always took gallbladders out, it would have been an open procedure. And then this new technology, laparoscopic surgery, came along, right? So if you think about a surgeon who is used to doing everything with an open incision, trying to move to laparoscopic surgery, that's a bigger change and involves changing not only their own skill set, but also those around them, thinking about the right equipment, the right technology, etc. All right, so ultimately this becomes a change management problem. So how big is the change? The bigger it is, the harder it's going to be, both from an emotional standpoint, but also from the logistics of how to do that. If you're not the only one that has to change, there's a lot more steps involved. There's great literature in this realm, in the business world, around how to do change well. And so my guess is some of you have actually taken a dive into some of this change management literature over the last few months as you thought about some of the curricular changes or the changes within the healthcare environment that have been driven by COVID. We have thought a lot about change management strategies. And so one of the things that my mind immediately goes to is communication. Oh, I can tell you how many times I have relearned the lesson about the importance of communication. You'd think I would know it by now. But the idea of really communicating well, over-communicating, I can have learned the perfect thing and sought to implement it incorporate it into my practice, but if I haven't communicated it well with the others that are impacted, I haven't actually adjusted the practice. And so again, we should learn from those that do this really well. And I would argue the business literature is one of the places that does that. Whew, that was a lot. Thank you for bearing with me and getting through each of those phases in that model. But I asked this question, how is it useful? If it's not useful, I've just wasted your time. So hopefully over the next few slides, I can show you that I think it is useful and can show you how. All right, so I want to use 3 quick cases. The first is a struggling medical student. This is Susie. She's a 3rd-year student on pediatrics on her clerkship. She's excited to be at Children's Hospital because she thinks she wants to be a pediatrician. She's overwhelmed at the end of each day with all of the things that she didn't know. She dutifully keeps a list of unanswered questions in her little notebook. I don't know if any of you had actual spiral ring notebooks like that. I did. Carried it in my white coat pocket, wrote down lots and lots of questions. But like Susie, I'll be honest, at the end of the day, I never seemed to be able to find the time to investigate all of those. So the list of questions grew, but I felt more and more overwhelmed. So as we think back to the 4 phases, the planning, the learning, the assessing, the adjusting, where is her problem? She's identified a lot of gaps, but I would argue selecting one of those for learning is where her problem is. So this is a place where a really good resident could be helpful to say, you know what, of the 3 things you just identified, let's pick management of electrolytes in patients with diabetes, specifically diabetic ketoacidosis, because you have a patient with that. So let's dive into that topic and prioritize that right now. So again, students can do this for themselves, but that external perspective can be helpful. All right, let's go to the case number 2. This is Tommy. He's a 2nd-year medicine resident. He really wants to do well. He tries to spend time each and every night reading and rereading systematically through Harrison's textbook. He underlines and highlights as he goes, but he can never seem to remember what he read. I'm sure none of you did this, but I was actually given this advice when I was an intern. It wasn't Harrison's because I was a pediatric intern, but I was told, pick this book and read it from cover to cover, and that's how you become a good pediatrician. That was actually horrible advice. I tried it, and I really, over and over, showed how I failed. And so, if for me, again, I'm being honest, or for Tommy here, where is the issue? He hasn't really identified gaps up in the upper right, so it could be a planning issue, but he's definitely not using an effective learning strategy. So again, this is one of those places where we can come along and help with that. Finally, Sandra, she's a busy junior faculty member who works in a family medicine office. A month ago, she realized her diabetic patients weren't as well controlled as she'd like. She invested time and energy in searching out and appraising the literature. She identified great evidence-based intervention to address the problem specifically. She feels like it should be really effective, and she's actually got buy-in from her partners about the idea. She's stuck, though, with how to practically implement the new program in her clinic and all of the changes that that will lead to, and it's actually led to frustration amongst the staff there at the clinic. So where is her problem? She's actually done the gap identification. She used good learning strategies. She actually sought it out with her partners to assess if it was the right thing. Her issue is over here in the adjusting phase, actually incorporating that into practice. So I hope these 3 examples have shown how this planning, learning, assessing, adjusting model that has self-regulated learning at the core of it within this master adaptive learner framework can be helpful to identify issues within ourselves or within our trainees. Whew. Does anybody else feel like that? Brain is full? Okay, so I just want to quickly summarize and then we'll take some questions and spend some time doing that. We started with why is expertise important, and I talked about those 2 gaps. The gap between what is known and what we do, and the second gap, what is known and those novel challenges that we are faced that we need to solve. Then we talked about expertise. Routine expertise is the efficient application of known solutions, taking those off the shelf and applying them, versus adaptive expertise, which incorporates new learning, integrates it with innovation to solve those new and novel challenges. And then lastly, we talked about how do we develop this. And so the Master Adaptive Learner model is one that is very literature-driven, that talks about planning, learning, assessing, and adjusting. But it also tries to incorporate those characteristics of the learners, the curiosity, the mindset, the motivation, the resilience, the ability to use that external perspective of a coach, but also being cognizant of that this all happens within the working learning environment, and knowing that that can help, but it can also hinder. And so for the times that it hinders, we need to be very thoughtful about how can we address and change the environment in a way that actually improves the learning also. So I want to pause there. I look forward to taking questions from you, and I'm incredibly thankful for your time and attention this morning.
All right. Thank you all for hanging with me. It was a lot of fun to spend that time. And so I would encourage you to think through now over the last few minutes we have, if there's a question you have, to be able to put it there on the side. We'd love to try to address those if we can, but really thinking about either yourself or about learners that you've worked with and how this model might help you identify where you're getting stuck or where they are getting stuck, where you could offer a little bit of extra support, how you could serve as that coach role, how you could find someone that could serve as a coach role for you. So as we think about that, again, high level metacognitive approach to self-regulated learning, how can we do that in a way that really leads to that adaptive expertise where we really want to be able to solve the problems for the sake of our patients, to really serve them well? And again, I hope that for each of us as physicians, as nurses, as therapists, as trainees, as healthcare providers, whatever our role is, that we're always wanting to do the most current, the best for our patients, as well as trying to solve the challenges that we confront. Again, there's a lot of things that are going on in our current context that we're not necessarily aware of or haven't been prepared for, haven't had to solve in the past, and we need to be able to dive in and do that. So I want to look and see if we have any questions. So I see a question around when is a good time. I think it's a really important question. Thank you for asking that. The easy answer is I don't think there's a one definitive right answer. So I think part of that has to do with the relationship that you as a coach might have or as a practitioner might have with a trainee. Some of it has to do with relationship. Some of it has to do with, is the patient at risk? And so if there is any risk involved, potentially acting or saying something a little sooner. But for us as just kind of the practicing clinician or for our trainees, trying to think about a normal rhythm that gets into the practice, that habit of mind that we mentioned earlier of consistently examining one's own practice. Again, it's hard to do. One of the things that can make it even easier is truly to have a data stream, to have information about your own performance. So for students, that comes in the form of assessments, whether that be a written test, an examination, or the feedback assessment forms from the clinical space. For residents, there should also be those assessments, although if I remember correctly, at least for me, they were a lot less frequent than when I was a student. And I found it harder and harder to get good feedback. So again, I think putting on the hat of a trainee, this is why they want feedback. This is why they ask for that over and over and over, is they really need that help to be able to make improvements in their own practice. And so that whatever those data streams are, it's important to identify those so that they can be used, can be helpful for identifying gaps in one's own learning or one's own practice that can lead to that further learning. So for me, that gap identification step is absolutely essential for ourselves, for our trainees. And so ideally, we would all be able to do this ourselves. I don't think that's always the case. And so this is where that external perspective or that external voice can be really helpful in at least posing a question. I mentioned it to a group of your faculty this morning. It was a great conversation, but one of my favorite ways to do this is to ask questions, is really to dive in, to ask a question that encourages the student to think or to examine his or her own practice in a way that highlights that. All right, let me see what our other questions are. Ooh, there's a question around how do we recognize the need for adaptive expertise? Like, when is the problem doing it? So this is a really, really tricky one. And I think a lot of it has to do with that moment of recognizing that the routine approach won't work. So I'll share a quick story of a case that I had that showed me the routine wasn't working in this case. So I was an ICU fellow. We got a call from the emergency room about a 4-year-old patient with a history of asthma who presented with wheezing. Patient came in, was wheezing, progressively got worse, enough so that ended up getting intubated, which for those of you that take care of children with asthma, it's pretty rare for them to need to be put on a mechanical ventilator. But this patient did. Patient comes up to us and to me in the ICU. We're giving all of the appropriate therapies for this asthma attack, beta agonist with albuterol and terbutaline and steroids and lots of different things. Patient is on the ventilator, really difficult to oxygenate and ventilate, to be completely honest, and just wasn't getting better. The next morning, one of my senior mentors came in and said, what if this isn't asthma? I was like, well, of course it's asthma. The patient has a history of asthma. They're wheezing, respiratory distress, all of those things. Sure enough, she was absolutely right. We did a bronchoscopy, and it turns out there was a peanut sitting on the child's carinum. So this was a patient that had asthma. They were wheezing, but it wasn't because of an asthma attack in this situation. And so for us, we needed to solve that novel challenge that I had never solved before. And it needed that outside perspective to be able to ask me a question that really allowed me to dive in and do that. And so again, I think sometimes that external perspective can be helpful for us to differentiate what is the routine, what is not. But hopefully over time, we each develop that ability to recognize, okay, routine approach isn't going to work here. This must require a newer novel challenge. And that's where I need to flip from routine expertise, which is really important. We can't have either or. It needs to be both. I'll flip from routine expertise to adaptive expertise for the benefit, for the sake of my patient. All right, let's see what other questions we have. So a question around how to build trust, really good question. And so the easy answer is, one, it's going to take some time. The question goes on to ask, do we provide this model to them? And so for our students, we actually do provide this model to them, and we establish a series of curricular sessions over time to help them really dive in, understand the content, understand the skills, the habits of mind, etc. That said, just teaching them about topics isn't going to develop trust. And so the question is a really good one in that, for me, this goes back to two things. One, is there a coach or an external person who is supposed to do this for them, but also that learning environment, that working learning environment. How can we craft the environment in a way that builds that trust? Are there longitudinal relationships that the environment fosters? What choices do we make in the UME side around grading and assessment of some of those? Do they foster trust or do they get in the way? I think that those are really important to think about how we shape the environment to produce or create that trust, or at least to allow it. I think there are plenty of things in the environment that can get in the way of the trust. Some environments seem to breed it or foster it a little bit more than others. And so again, for those of you that work in the clinical realm, thinking a lot about the trainees that are around you, thinking about your own colleagues, what are the things that help foster trust? So Brene Brown is one of my favorite kind of leadership authors / researchers, and she talks a lot about trust and what is required to it, what is required to develop it, and it unfortunately requires some vulnerability. You would think that you have to trust first and then you can be vulnerable, but she flips it around and says you have to be vulnerable first before trust can be. And so I'll be completely honest, one of the things that I do to develop trust, but also to role model, is to tell students about my own struggles, about my own opportunities, my own gaps, and how I have tried to address them. It is not comfortable to talk about errors that you've made or gaps in your own practice. But if I'm able to demonstrate that for the trainees that work with me on my team, I am able to really send in the message that this is important. I'm able to show them at times how to do it. And then I think that my vulnerability allows them to establish a little bit of trust. At least I hope so. These are some great questions. I really appreciate it. One of the things, let me see if there's any more. No, I think we're good. One of the last things I want to leave you with is, remember at the beginning, I put up a little note card slide. I want you to circle back to that. If you have a note card or a scrap piece of paper, think back through the talk. So you've now spent about an hour with me. Was there one reference, a book, a journal article that you want to track down? Write it down. Was there one strategy that we talked about that you would like to use with a trainee at some point over the next week or two? Write that down. And I encourage you to write it down very intentionally, because there's actually really good literature, and I mentioned some of it earlier, that most of you won't do anything. But if you go to the act of writing something down, you're far more likely to actually follow through on it, myself included. And so I would encourage you with that thought. What is the one strategy that you would like to think about or potentially try over the next week, next 2 weeks? Again, and it can be something for yourself, thinking about the planning, learning, assessing, adjusting. Is there somewhere that you want to try something new? Or from a coaching external perspective, who could you help? How could you help a trainee? Where might they be getting stuck? And how could you be able to help them in that way? Let's see, one more question. I think we might have time for it. How do you see EPAs and ACGME milestones benefiting the use of adaptive practice? from the use of adaptive practice. I think this is really, really important. And so for me, there is a tremendous overlap between competency-based medical education, master adaptive learner, and the development of adaptive expertise. For me, the easiest way is that all of that competency-based medical education data, the milestones, the competencies, the EPAs, that can serve to help illuminate for the trainee where their gaps are, right? Those are great data streams to help highlight where the gaps are and allow them to dive into a cycle to learn about that. At a higher level, thinking about our current assessment structures and do they reward routine expertise while ignoring adaptive expertise? And this is one where there's actually a lot of work to be done. Working with a few colleagues around the country to try to think about how do we assess, how do we measure this type of adaptive expertise? And we're just not there yet. We're working on it, and hopefully we'll have something in the next year or two, but we just don't. Marie Malopoulos and Nikki Woods, who some of their work I mentioned earlier, have done some really interesting work around assessing pre-clerkship students around this ability to develop adaptive expertise. So they test off of a scenario that they're given. The test questions are different than the scenario, but if you really learn from that first scenario, you're able to apply those lessons to a new novel solution. So it's a really interesting way to test and to assess. And I hope that that actually has some applicability to those of us that do GME work that are thinking out in the other realm. So I'm really grateful for the time. I see that we're hitting up on the noon hour, or the 1 hour. It's noon for me, I'm in Central Time. We're the end of our time together. So again, I ask you to circle back to your card or your scrap piece of paper. What's one thing that you want to do over the next week to try to dive more deeply into what we've talked about today? I'm incredibly grateful for your time and attention, great questions that you ask, and I hope that you have a wonderful afternoon. Thank you.
Casey McQuaid, and I have with me Dr. Michael Simonson and Dr. Amr Kohli. Today we'll be talking to you about hashtag SOME, using social media in academic medicine. I was also asked to remind you guys that you can post questions as we go through our presentation today within the YouTube chat. We will make time at the end to get to your questions then. Also, my friend Michael wants to remind you that if you want to write something down on a note card now, you can tweet it at us later, and we'll be happy to respond to you on Twitter. Okay, with that, we have no conflicts of interest, although we do all use social media. And then, honestly, as we were preparing this talk, we've all given a version of this talk throughout the years. It's been quite a bit different, though, preparing it for this setting because of the thing called the COVID pandemic, which has more or less made all of our education lives turn upside down. Just for instance, reflecting on what we're doing now, we are presenting, Amr, Michael, and I, from 3 different spots using Zoom, broadcasted to YouTube, which is in itself a form of social media. And even as I was preparing this talk and was perusing Twitter, I found what you see on the left, which is an example from Vanderbilt's internal medicine residency, where their program director, John McPherson, posted a picture of their residents taking part in socially distanced virtual morning report, where you see people spaced around a room, presumably people were in other team rooms. And he was advertising this as something innovative that they do at Vanderbilt. It truly is innovative. We do it here too, on social media. And I also came across what you see on the right, which is a slide. I think it's probably from something ACGME or AAMC related, talking about virtual interviews. And all of these things popping up on social media brought me to my next point, which is, I don't think, Mike, if you go to the next slide, I don't think that virtual education, recruitment, or education is going to go away anytime soon. And on the next slide, another point, social media use by residents and faculty isn't going to go away anytime soon either. Just to give a little data to that effect, here's a paper from the Western Journal of Emergency Medicine. ER docs, far and above any other specialty, were onto the social media, the open access education field way before anyone else. And this survey from a couple years ago showed that in a pretty broad survey of emergency medicine faculty and residents, 30% of residents and a quarter of faculty used social media daily. And it's not like they were just using it for news, entertainment, or videos. They were using it for things like research, for advertising events, for networking with colleagues, things that we would all do at like a Med Ed Day, at SIGM, at ACP, at whatever your conference of choice is, in person, if we were still doing those things right now. Some data from our own group that we haven't published yet. We surveyed UPMC, internal medicine, and pediatrics residents and faculty. and found that over 3/4 have some sort of social media account, and 61% of those are using their social media accounts at least daily. So this is fairly popular thing. It's not going away anytime soon, and people are using it for professional things. But wait, you say, I am a scientist, and you're talking about using this for education, for network, etc. You want to see the hard data on that. Well, there isn't a whole lot published. There are some things published. Here's one of the best examples taken from one of the original versions of this talk that we give. Gamified Twitter microblogging to support resident preparation for the ABSite. So what this group up at UConn did is they took board prep questions and put them onto Twitter, and they had residents race to provide the correct answer to these questions. And they gave some sort of brownie points or kudos to folks who answered it first. And they found that folks who participated in this and did well in this initiative ended up doing better on their ABSite exam from constant participation or in association with constant participation, as opposed to people who didn't. Now, we can argue about causality versus association. Is it the people who are already on the ball who are using social media? And those were the ones who did well on their ABSite exam. It's going to be hard to prove that one way or the other, but it's at least some positive signal that folks are using social media professionally and for education and doing well with it. So, social media is a tool that can help you learn, it can help you network, and help you, as we'll get into later, self-promote. So really understanding how to use it and how to use it well can only help you in your professional career. So as a consequence of going through this talk with us, we expect you to be able to answer the following questions. What is social media and what is content? What social media platforms are out there and which ones should you use to enhance your learning and education, to network with colleagues and promote your accomplishments and those of your colleagues? And how do you create and choose content that's appropriate for your career goals and your own personal or departmental social media mission? And to go into the first part of this, I'm going to throw it over to Michael.
All right. Well, thank you, Casey. Before we tackle what content is, I think we should take a step back and go to the beginning of kind of online learning. And if we do that, we can say that back in the day, there's this thing called free open access medical education, which was conveniently abbreviated to FOMED. And the emergency medicine people really got ahead of this early and started using this. And so how this manifested was in things like blogs. So online, people would post things. Here we have Life in the Fast Lane, something that most of you may have either intentionally or accidentally stumbled upon online, that gives you EKG readings, kind of some critical care learning points. And then one that you might be a little bit more familiar with, podcasts. The example given here is the Curbsiders. You can listen, learn, people will discuss topics. These are both great ways to deliver content to people listening. But both of these things, both of those platforms have a problem, and that's that they lack significant interactivity, which is an important part of good, durable learning. And so that's our cue to kind of come onto the scene with social media. And so what is social media?
Well, I'm glad you asked, Michael. So in going along with our theme of using social media to help explain what social media is and give examples to you guys, I've pulled a slide from Dr. Avital Oglasser's tweetorial, which is a thread of tweets that she created to go along with her August 7th, 2018 Medicine Grand Rounds on social media. So a little background on Dr. Oglasser. She is, if you'll click next, Michael, she is an APD at OHSU. She's a hospitalist. She's an expert in perioperative care. You may have heard her on the Curbsiders recently. She's also an expert in using Twitter for academic purposes. And she, in her talk, defined social media as a digital medium that helps people create, share, and participate. So for the purposes of today's talk, That's the definition we'll be using. We'll primarily be talking about using Facebook, Twitter, Instagram. We'll have a little discussion about which of those might be best. We might touch on TikTok, although that may or may not still be illegal in the United States in the coming months. And so keep this in mind as we go through. Social media is a digital platform where people like us, potentially educators, people who run departments, create content. They share that department with other people for general consumption and also to promote participation, which, like Michael said, helps everyone's education.
Great. So hearing that definition and seeing that there are multiple platforms out there, you might be saying, which one should I use, or how do I choose which one to use? So we're going to go through a couple of the most common ones to help you kind of understand what the differences are. And the first one that you think of is probably Facebook. It's been on the scene for a long time, and it has the most users of any social media site at 2.7 billion monthly active users around the world. People use this to connect between them and their friends, their families. It's really good at creating groups of people with similar interests, and that's actually what their advertisement campaigns now are promoting. One of Facebook's strengths is that the content you can make there is diverse. They support a lot of different platforms of text, lots and lots of text, images, videos. You can link to other websites. You can include URLs, articles. And what they did a couple of years ago was develop something called the Facebook Messenger, which allowed for an instant messenger-like chat function for other people who are on Facebook at the same time. So it allowed for that interactivity between users. But the question is, does this work for academic medicine? It has a lot of usability, but people don't really use it for this. It could work for teaching and education, but people don't really want to mix their private life with their friends and their families with what they're doing in school or at work. So the pros, it's very versatile. It can do a lot of things. The con is no one's going there to actually use it for education. Instagram, on the other hand, is an image and video sharing site that's actually owned by Facebook. And what this does is it allows people to share images and videos. And that's really all it does. You can create captions, you can put text in captions, and you can comment to some degree, but there's no outside URLs to increase the security of this app. So you can't link to other websites, you can't link to other content. It's really kind of, once you're in the app, you are in the app only looking at the images and videos there. So does it work for academic medicine? It can in certain situations, but the interaction is limited. Your comments are only 1 or 2 comments long. You can't create strings of interaction. The pros, people love pictures, and that's what Instagram does. It draws people in and it will encourage their use. The con, you can't link to other stuff like original articles. So if you pique someone's interest, they have to leave the app to actually get more material. That brings us to Twitter, which is a microblogging social media platform. You probably know it from its particular relevance in a lot of our culture today. It allows for individual posts with a character limit of 280 characters. It used to be 140. And interestingly, it has a strong medical professional community, #MedTwitter. It allows you to share text within that limit of 280 characters. It allows for some images to be shared. It allows for actually short videos. And a couple of the things that it's added recently are polling features. So you can actually quiz people or get other people's opinions. And it allows for direct communication between users. You can create strings of comments or chats. And like Facebook, they have a direct messaging system as well so that you can chat more privately. So does it work? Yes. MedTwitter is actually a very large and active community. If you aren't on Twitter for this purpose, you may not be aware of this, but there's actually a robust community out there. The pros of Twitter are actually that it allows for significant interaction between users, and it supports it has the versatile content support that Facebook might have. The con, character limits. You can only create 280 characters, but you can overcome this in certain ways, and we'll talk about this a little bit later in this session. That brings us to TikTok, and I don't want to spend too much time on TikTok. hopefully less than 60 seconds, just like the videos that you can post on TikTok. TikTok is basically just a way for users to post short videos that allows them to change speeds. You can slow things down, you can speed things up, you can add music in the background. You can kind of interact, you can like things, you can create some comments, but primarily communication between people is in the direct messenger system. It's not about the content that's posted. And so I'm just going to skip to, does this work for academic medicine? No, not really in the format that it is right now, but you should know about it because the youths are using it, and maybe as they add some usability features or it becomes illegal, there may be other ways to use it down the road, but right now it's not really an effective platform. So let's back up and remind ourselves, what is content? What did we say content was? From Dr. Glasser's definition in her talk, she said that it's a digitally based medium that helps us to create, share, and participate. And so you've heard me using this word content, and what is that? So content is what you decide to create or share. It's the videos, the text, the images, the tutorials that you create, the discussions that you have on that platform. And that's going to be important as we go forward. So I'll pitch it back to Dr. McQuaid to talk about how you can choose certain content to craft the message on social media.
Yeah. All right. Thanks, Dr. Simonson. So essentially, the content that you create and that you publish onto social media creates your image on social media. So, for instance, as an individual, if you primarily want to be an educator on social media, you should create educational content, post journal articles, tutorials, network with other colleagues. If you primarily want to use use social media to dialogue about research, which people do on Twitter, then you can post article commentaries, interact with other people who are doing the very same thing. We're going to give you guys examples of this in the coming slides. It's also possible to have a departmental presence on social media, which you can use to promote your trainees' accomplishments, to advertise their wellness, that they like your programs, that they wanted to come to your program, and that you too should want to come to their program, use it for recruitment, and to also use it for event coordination. So how you interact with folks on social media and the content you create depends upon what you want to accomplish as you use social media. It's not as hard as you think, but it does take some thought. If we go to the next slide. So what we're going to do now is go through examples. Dr. Simonson and I, first for educational modes on social media, and then we'll go through the promotion of scholarship, and then also touch on some of the departmental modes, for instance, recruitment of new trainees. From the educational standpoint, I'm going to go in increasing order of complexity. So starting with some of the most basic things you can do, like posting articles or clinical pearls, and then work down to slightly more complex things like quizzes and tutorials. So starting out with posting articles, you can see on the left-hand side of the screen, I've taken a screen capture of Twitter from one of my friends and colleagues, Dr. Drew Klein. He posted, you can see this is a little bit dated, but I still think it's a relevant example. He posted, the evidence grows, beware of bleeding in upper GI cancers, and then posted a link to the SELECT-D trial as it was published in the Journal of Clinical Oncology. And you can see what he's done here. Very simple, very little, sparse, but relevant commentary up at the top. And then he's posted the name of the article and then a link to the article. Succinct, gets the point across. As another example on the right-hand side, this was actually taken from the Pitt Cardiology Fellows Instagram account. Now, remember what Michael said. He said Instagram is just primarily pictures, and there's no outside URLs. So what they've done is they've taken a screenshot of the abstract and posted that directly onto Instagram. And to get around the lack of outside URLs, whenever you scroll up on Instagram, they have a little description of the article with bullet points. They advertise Dr. Lindsay Seeley. You can see that they're using this not only to post the article, but to promote one of their recent trainees who had published this article. And then they go through and they summarize. So you can get a little bit more detail out of Instagram, but you're limited. You can't actually link to the article. Something that I think is really revolutionary and really fitted to the current era of distance education that we're in was Nephrology Journal Club, or NEPHJC, as you can see over here in the corner, this hashtag NEPH capital JC. Nephrology Journal Club was started several years ago by Joel Topf, Matt Sparks, some of his other colleagues. What they did is they said, hey, everyone, on Twitter, we are going to discuss an article this month about IV versus oral iron. We're going to do it on Tuesday at 5 p.m. Log in. We'll have a couple questions and we'll be able to have a back and forth. And what they did is they were able to get people to participate. And you can see this graph. It's the different topics. And on the x-axis is the number of tweets that were generated with the hashtag Neph Journal Club. And you can see they were generating hundreds of tweets by advertising their intent to discuss a journal article and then doing it asynchronously on Twitter. This was massively popular on the medical Twitter community, specifically the nephrology Twitter community. And they had very high-level discussions on this. So Journal Club is something that can be adapted to social media as well. Next, so that's posting articles, which can be as simple as posting a link or as complex as having Journal Club. Let's talk about educational pearls, something else that's pretty cheap and easy for you to do. So here on the left-hand side is a screen capture from Facebook. Another one of our friends and colleagues, Dr. Kristen Ehrenberger, has a Facebook page that she calls Teaching Rounds. And every week, on each day of the week, she goes through and posts another clinical pearl on a particular topic. This week, she's posting about pediatric oncology. So this is actually taken from this Monday. She was posting about Fanconi anemia, and it's a disorder of ineffective DNA repair. And so if kids have Fanconi anemia and need treatment for cancer, you have to do special things because of increased toxicity. I didn't know anything about that, probably because I'm not a pediatrician, but it was educational nonetheless. On the right-hand side is an example from Twitter. This is from Temple's IM residency page, and they have posted a clinical pearl about using MRSA swabs to rule out MRSA pneumonia. Of course, you'll notice there's a lot more text on Dr. Ehrenberger's Facebook post than there is on Twitter, but Temple has gotten around this by posting a screenshot of some sort of slide, perhaps from a presentation like this that they were giving. It's a way that you can add images, that you can add more text to your Twitter post. And like Michael was saying, one of the ways you can get around that 280 character limit. Okay, let's move forward. So quizzes, this is starting to get into some more direct interactivity other than having people post back and forth with you and have a little discussion on Twitter. You can have people answer questions almost like a test. So like on the left-hand side, the Lewis Katz School of Medicine Medical Clerkship has a Twitter page, which I would recommend that you guys follow as a good example of how to do this. They've used the case report format. So they've posted a little clinical vignette, someone coming in with right upper quadrant tenderness, jaundice, and I think a fever. Yep. And then they've asked, what sort of testing would you like to get next? And they have used the polling function, which people can vote for different answers, like a test, like a quiz. And then on the next slide after this, they actually give the answer. No, that was in Twitter, Michael, not the actual next slide. That's okay. So a similar type of a thing you can accomplish with polls. The Indiana University Infectious Disease Fellowship has just frankly asked a question. They've said, here's the rash. Someone was getting up and close with some prairie dogs that they had purchased. What is the organism? They don't give any sort of quiz for you to answer. They expect ID fellows who are using this to, again, help prepare them for the boards to just answer, hey, it's monkeypox. So people end up replying, they give their answers, and then several hours later, they give their answers. So you can give people a chance to answer and then validate their answers, yes or no, with the correct answer afterwards. Now the actual next slide. Okay, thanks, Michael. So now we'll talk about the most complex thing you can do on Twitter. It takes a little bit of work, but people get a lot of learning through it. It's called tweetorials. So this is a Twitter tutorial that's been combined together to be the word tweetorial. It's a series of tweets about a single topic arranged into a thread. And if you really study them, you'll see that they generally go in a pattern, and they use the very things that we've been discussing up until now. A Pearl followed by a quiz, followed by an article, so on and so forth. And the best example I can give you of this comes from Tony Brew, who's faculty up at one of the Boston institutions, and he posts tweetorials on various thought-provoking topics. This one from a little bit ago was, how does acetaminophen decrease fever and pain without affecting inflammation? And so what he does, so he poses this question, and then going forward, what he does is he posts then the quiz. He lets people choose their answer, and then he goes about explaining it. So he's done the question, the quiz, now a link to an article. And on the next slide, we'll see he just keeps repeating. He says, okay, so what's the next question? We'll answer that with a Pearl and an article post. And over many tweets, he eventually gets you to the answer. And he says, well, it has to do with the receptors it chooses, and it has to do with altering the hypothalamic set point. That's great. We've learned so much from a series of tweets, and unlike some sort of summary article that you might find on Annals or you might find on the New England Journal, you've been able to interact using the polls as a quiz throughout to enhance your learning on this topic. So to sum up about tweetorials, it uses this posting of articles, posting of quizzes, posting of pearls that we've talked about before. It takes a decent amount of work to put together if you have to find all of those articles to collate them together and then develop your questions. That's going to take quite a bit of time to put together. But it's a really well-established medium on Twitter, and people get a lot out of it, and it will generate you a lot more likes and retweets on Twitter. The downside of that is putting the time to put together a tweetorial takes away from time where you could have, instead of generating the 18 tweets in the tweetorial, you could have generated 18 individual article tweets. So you're getting a lot less foot traffic, perhaps, on your Twitter feed for one big tweetorial than you could if you put together 18 different tweets. So that's using education on social media, or being an educator on social media. I'm going to hand it back over to Dr. Simonson to talk about the next two avenues you can use social media for.
Yeah, thanks. So as we move past educational uses of social media, we can think about how social media can be used for trainee recruitment, promotion of trainee accomplishments, and in general support for trainee wellness. And when we think about all these, there's probably considerable overlap. And so some of the uses may morph into one platform or the other. But we'll hopefully provide some specific uses that could be relevant to you or relevant to your department. So starting with promotion of accomplishments. Here, I'm going to show you a bunch of tweets by the UAB Internal Medicine Residency, Maryland's Internal Medicine Residency, Ohio State, and Temple. All of these are program level Twitter accounts that are taking accomplishments. In this instance, all of these are either abstracts, presentations, or manuscripts that have been accepted by their residents and broadcasting that over a fairly large audience. And so what you can see is that they're congratulating these people, they're mentioning people by name, and then they're also mentioning and tagging the article, or the journal that's being included, the meeting where this is being presented at. Obviously, this is something that might be amended over the next, couple months. But the online presence, and so you can tag these these places, and that increases the reach of each of these posts. So you can get the accomplishments of your trainees out to a larger audience. And you don't need to be a program to do this. You can actually do this as an individual and share your colleagues' work. You can do this for your own work. As you get an article published, you can promote it by sharing it. And in fact, that's what you can see with Maryland and Ohio State here. They are actually sharing the promotion tweet of the actual resident and giving it kind of more legroom. The Pitt fellowship programs the Pitt palliative care here and then USC medicine here, they are not quite addressing the publication accomplishments, but awards. And so on the left, you can see the Pitt Palliative Care Fellowship is acknowledging Jane Schell for getting a career award. And then on the right, you can see kind of end of year awards for the residents that have been presumably elected by their colleagues. And so this is actually a demonstration of how on the right you have Instagram, and you can see how this picture format really plays to kind of this simple acknowledgement of accomplishment, whereas Twitter uses a lot of text, but they can link to information about that award. So what accomplishments might you want to share? It depends really on what image you want to project. If you're trying to share scholarship, you can share the publications that your residents or that your colleagues or that yourself are publishing. You can share what you're doing at workshops, presentations, or you can kind of go towards the awards from your residency, your institution, or from national societies. Some programs may want to highlight personal accomplishments outside of the hospital, such as weddings, babies, birthdays, to show a more humanistic side of their employees or their trainees, things like that, obviously with the consent of the persons involved. Thinking about recruitment, the highlighting of accomplishments is part of recruitment to show that people who are trained or who work at a certain institution are successful. But other ways that this is done on social media, if we go to Twitter, I think that the VCU internal medicine residency Twitter page is actually an excellent example of how you can increase the visibility of your program fairly simply. You have a bio section here, and the words that you put in are limited by the same character description, but they've used it very effectively. Our mission is simple: to train the well-rounded internist of the future, competent, caring, compassionate, and confident in the practice of internal medicine. I have finished my residency, but after reading that, I'm kind of interested and I might want to apply to another residency. Won't take me long to say no right now, but I think it's inspirational nonetheless. You can think of social media as an extension of your program website in terms of getting information from your program to potential applicants. And you can think of it as a demonstration of your program community. So that's going to be acknowledgement of personal or professional accomplishments, or acknowledgement of interactivity between your trainees. So on Facebook, the Einstein residency program in Philadelphia has a Facebook page that is public, one of very few across the country. But they use Facebook to share information. This kind of gets at the versatility of Facebook. They have a lot of information about the type of program and who they are. But they also have a feed that shows what educational programs are happening, who is involved, and how they're delivering content to their trainees. And so you can visit their page and see what they're doing. On the other hand, the Pitt fellowships use Twitter very effectively to advertise their fellowships. And so here we have the Hospice and Palliative Care Fellowship again, and the GIM Fellowship. And what they do is they use the versatility of Twitter, similarly to Facebook, to present information, but they use images to actually show information, in addition to the 280 character limit. They also use Twitter to share links to their website. So you can click on those links and it will take you to the websites for these fellowships to get more information. And another thing that Twitter allows you to do is it allows you to connect. So by tagging other fellowship programs, by tagging specific people, this post or this content will be shared to other people's feeds. And so more people will see this post as a result of that. And so this is a great way to get information out about these fellowships, and it's something that's done well. again, this might take a little bit of time and a lot of planning. Obviously, these are well put together slides. On Instagram, you can do similar things, but again, the interactivity is limited. And so you can look at different internal medicine programs and what kind of image they want to project and say, we have well-rounded people, they get along well together, they have flourishing social lives outside of the hospital, or they go to trivia. And you can see that maybe these social events are sponsored by the program. Here's a picture on Instagram about a trivia night. But there's varying levels of privacy here. With the trivia night, you might be interested, it draws your attention in, but there's actually no information for people who aren't in the program to get there. And so you can see it references an email, so people within the program are then getting an email that they can reference. So this is an advertisement, almost like hanging on a bulletin board in the hallway for residents to see and then say, hey, I might go to trivia night. Something to think about. So with that, I think that a lot of you might be thinking about, well, isn't our website enough? And so with that, I'm going to turn this over to Dr. Coley.
Thanks so much. So I think by this time in the presentation, I think everyone listening has a really good sense that both Dr. Simonson and Dr. McQuaid are truly experts in the use of social media and kind of using it from an individual standpoint as well as a program standpoint. And while I'm here primarily for moral support, I'm going to talk about two kind of things that I think as we were building kind of programmatic platforms in social media, we got a lot of questions about. And the first one primarily is, why isn't what we have good enough, right? And so every program has a website and that which they use to kind of collate and cultivate a lot of data. And so if we move to the next slide, you can see that, so the benefits of having a website is that you can put a lot of information in one spot. And then once you get that information in there, as long as it is relevant, like pictures of your residents, it requires very little day-to-day upkeep. I think the difficulties with websites in general is that they can often feel impersonal. And what happens with websites is that they just become larger and larger as your program becomes larger and larger. So you keep adding content, but very rarely are we removing content. And so as we kind of add stuff, we may lose things in different links or sidebars or something that may become out of date, and we may miss them. And so then this overhaul of a program's website becomes really difficult to achieve. One other thing to note is that as you add more content and data to your website, the website itself, its physical space in the internet gets bigger and bigger. And because of that, it takes longer and longer to load, either on your Google web browser or on your phone, whatever that may be. And that actually becomes really important in this day and age where we have shorter and shorter attention spans. And so a company that found this really important was the Google Corporation. And they did a study that looked at websites and how quickly they loaded. And they looked at when, if a website had not loaded by a certain time, would a user just X out of the website and move on to something else? And they found that more than about 60% of people would close out a browser or close out of their phone if the website didn't load in 3 seconds. And so that seems like not all that long. But interestingly, our internal medicine's house staff's website takes about 5 seconds to load. And so it just has a lot of content, right? It has a lot of stuff to get out there. So that's one thing to keep in mind. Finally, it becomes very hard because you're not updating this day to day to highlight individual achievements that kind of happen periodically, whether that's fellowship matches or publications or things like that. So we're going to move on to the other things to consider when, from a program standpoint, how are we going to select a platform and how can we really make this worthwhile to everyone else, and how can we make that content really matter? And I think the first thing to note is, while Dr. McQuaid and Dr. Simonson have noted how exactly certain platforms are easier to use than other platforms, there's still time required to dedicate to maintaining program site. Also, you need to consider who's going to be the person that's providing the day-to-day upkeep for the site overall, and how much time is that going to entail. And so finding someone who really is passionate about using the platform and promoting the program is really essential. After we find a program champion, the other things that are important are kind of, I think, starting small. And then we can look at kind of what is the program's current platform or project that they like to promote. I think just programs have multifacets. And so picking one thing in particular, whether that would be promoting wellness, whether that's diversity and inclusion, whether that was like promoting ITE exams in that UConn study about the AppSite scores. I think picking one thing and starting there and using that first so people get an idea of what the content will be and then expanding would be really helpful. The final thing to do is kind of get a sense of what your program's personality will be like. What is the content going to be? How lighthearted, how specific, things like that. And I've utilized kind of 3 large media shows / corporations to kind of give you a broad spectrum of kind of the overall personalities. So in all of the personalities I'm going to show you, the whole idea is that you report the facts, right? And so that is kind of the baseline. And so our first kind of all the way on one side of the spectrum is NPR Morning Edition. They are an unbiased approach. They just give you the facts and they let you make the decisions. They let you digest the content yourself. And so an example of that will be like from our endocrines department Twitter account, where they tweeted, where they're a publication by Dr. Kordakowski on type 2 diabetes. So if we move a little bit down the line from Morning Edition, now we have The Daily Show, right? And so The Daily Show's job is to still report the facts, but basically put their own personal spin and maybe add a little humor or something like that. So we've cycled back to Dr. Topf, who we've talked about earlier with the NEF Journal Club. And so you can see that he is having a Twitter post here where he's talking about one-pagers for the ICU. And he's asking, why isn't our MICU wallpapered with these pagers, right? And so reporting the facts, but providing his own personal spin. So if we go all the way down the line, right, to the other end of the spectrum, you have the Howard Stern Show, which I guess is reporting facts mostly, but with a lot more flair and really a goal of also providing humor. And so I think the best example of this side of the spectrum is an ophthalmologist who has a Twitter account and actually a pretty big TikTok account. And his name is Dr. Glockenfecken. And so in this tweet, he's still reporting facts. Let's talk about floppy iris syndrome. But then he follows it up with additional humor. And that's kind of his MO. And he says something like, that's right, and especially with complicated words like Glockenflecken, we have a thing called floppy iris syndrome. It's time for an ophthalmology urology crossover you never thought you needed and probably still don't. Right. But then he proceeds to talk about the pathophysiology of alpha-1 blockers and actual important facts. So you're getting learning, but you're also entertained. And this is a complex task and something that you have to become very comfortable with. But that's kind of the idea of the personalities.
All right. So if hearing all of that and trying to put it all together, you've probably got a lot running around in your brain. You're trying to pick what you should do and how you should choose your content. We'll try to help you out here. So if you have a certain mission, what social media site do we think you should probably use? If you're interested only in educational material, whether that's sharing educational material or absorbing it yourself, probably Twitter is the best. It allows you to link out to original articles. It allows for more interaction. It allows for some of the more complex tasks. Facebook does allow that, but again, it's just not used by enough people for that purpose. And most people on Facebook are not trying to combine personal and professional lives. And that's why Twitter gets the nod. If you're trying to recruit trainees for your program or your division or your department or your clinical section, either Instagram or Twitter could be used effectively. So Instagram has those pictures, and people love pictures. We will keep stressing this. People love pictures, and that's what Instagram does. And so you can get some information out to people. You can increase their interest, but you can't provide as much content. Twitter allows for some of those pictures as well, but allows for slightly more content, allows for more complex types of posts, and allows you to link out to departmental websites or fellowship websites, residency websites. So you can kind of link to more information if you need to. So that's why I think it's a tie between those two, depending on what kind of advertising you are looking to do. If you're trying to promote scholarship of your trainees, of your faculty, then Twitter is the best way to go. For similar reasons as the education material, it's just easy to share material on Twitter that people can then investigate more. It's easier to link to the journal websites. It's easier to have a discussion about the accomplishments of people. And so overall, Twitter has a robust medical community, and that's why it's been developed, and we would encourage you, if you haven't, to explore that. So what if you're overwhelmed by Twitter and get angry thinking about it, and you just want to get your feet wet? Well, just pick Instagram. It's very simple to use, actually. You just upload pictures. You can make a caption, and that's all you have to do. Depending on the time commitment, although it should be said, when you have a departmental account, at least, you should have some regular posting to try and keep it current and keep people aware of its presence. But Instagram has an easy platform. People love pictures, and it requires a little less understanding than Twitter. It just doesn't have the functionality that Twitter does.
All right. Thanks, Michael. So the last couple things we wanted to give you guys some disclaimer and additional perspective on using social media for all these different names. So first and foremost, know your institutional social media policy. UPMC has one of these. If you are interested in particular for doing using social media on a departmental level, on a program level, on a division level, speak to media relations, go to Infonet and start looking up social networking, public internet communications, use of the institution's name and logo. The last thing we would want you to do is develop this great logo that uses UPMC's or Pitt's name or shield on it or anything of the sort, and then have UPMC or Pitt come back to you and say, hey, we love your graphic. Please take it down and do something different. No, we don't have any personal experience with that. But something else that would also potentially be helpful once you talk to media relations about how you can navigate the rules appropriately, develop guidelines for yourself. Decide, just like Dr. Coley was saying, who is going to run your account if this is a departmental thing? Who's going to have access to post materials? What type of content will you post? Deciding all of these things beforehand will keep you consistent and keep you out of trouble. Okay, so we realize we've gone through a lot of information. So on the next slide, we're sorry if you were overwhelmed. You're not alone. And like Dr. Simonson was hinting at, the first step is to make an account, whether that's on Twitter or Instagram. If you're on Twitter, search for the hashtag MedTwitter and peruse what comes up. Follow folks from your own institution on Twitter. See what the culture is on Twitter, and then you can start participating and posting along those same lines. On the other hand, some of you have been doing this for a long time, and we've given you guys a 50,000-foot view of using social media for academic medicine. We're sorry if this was a little bit high level or low level for you. If you have higher level questions, come find us, tweet at us on Twitter. We'll be happy to answer some of those questions once I finish up in another minute. You can also look on the Twitter feed that Amr, Michael, and I have put together at MedEdPGH, which is on Twitter. We have a pre-existing tutorial on how to craft tutorials and how to better advertise yourself either way, whether you're doing tutorials or just using some of the simpler techniques we've already discussed. And then eventually here in October, we're going to have a tutorial on using social media for your program mission to go together with a workshop we put together for Aptum then. The biggest strength of social media is sharing ideas with other folks. So when you see things that you like on Twitter, say, hey, I like what you're doing on Twitter, as one of my mentors told me all those years ago. And bounce ideas off of one another. That's the only way you're going to get better at this, by coaching one another. Okay. So in summary, social media, distance learning aren't going away anytime soon. Start using them now. Twitter's pretty powerful, but it takes experience to use. Instagram is easy, and people really love pictures. Can't emphasize that enough, no matter what medium you're using. Start small and post a clinical pearl. I think with that, we've gone through all the material we wanted to go through. Let's see if I can keep this window open and also get YouTube open so that I can see what questions we have out there. Dr. Coley and I are going to monitor the questions, and Dr. Simonson is going to keep Zoom running so that we can see what everyone has up there. So go ahead and type in your questions. We'll be happy to answer whatever comes our way. Just checking with my co-hosts. I'm not seeing anything in the way of questions if you guys aren't. Okay, then. Well, let me see if there's anything on Zoom. Not that I'm seeing. Okay, I have... Yeah, go ahead, Amar.
So there's one question from Dr. Kaizen asking, how do you suggest to monitor the validity of posts?
Yeah, so in terms of monitoring the validity of posts, so everyone worries about, this is actually something that was in an older version of this talk. So what happens when people post things that aren't valid or questionably true on social media? This is where the interactivity of social media takes over. People don't let that sit for very long. Someone else who has expertise in that area usually sees that fairly quickly and jumps on that. So as an example, there used to be a question on the MixApp database talking about what medication to use or to discontinue, actually, in a patient with MS who is admitted with acute kidney injury. And the answer choice that MixApp put out there was actually incorrect. Someone picked up on this, posted it, and said, hey, ACP, I think you have an error in MixApp. They posted it on Twitter. MixApp, ACP initially pushed back, and then Dr. Sparks, who you will remember from Neph Journal Club, chimed in, and a bunch of other nephrologists chimed in and said, no, actually, the resident who posted this is correct. The answer choice that is marked is not precise, and it should actually be both B and C. So there is a lot of peer review and self-correction that happens on social media.
All right. The next question we have is, any recommendations for where or how to find well-constructed, specialty-specific Twitter accounts for resident education?
So we had created a list. I don't know if we can share that afterwards, of different accounts that have expertise in specialties, maybe excluding pediatrics, but within the medical subspecialties. I don't know if we could tweet that out. Casey.
I think it's probably worth it. It's so a lot of the specialties have their own kind of hashtag going on. The cardiologists are very much on top of this. Hashtag cardio Twitter is just like hashtag med Twitter is its own very prevalent hashtag that's out there. Megan Acho is a pulmonary fellow who's posting a lot. There's generally at least a couple people who post specialty specific information. Like Michael said, we developed a list a while ago. We can probably put that out there for folks to look at on Twitter. We might find a way to get it to you guys also if you don't already have a Twitter page, so stay tuned.
All of the platforms have a search function, and you don't have to use specific hashtags. You can just search by keywords and it will bring things up. You will just get a less tailored list of results. So if you get onto Twitter or Instagram and you want to search cardiology, you can do that, and it will return some results of when people are mentioning those words. And so that's one possibility as well.
Perfect.
Yeah, and Melanie Nance gave us another example. So hashtag Shent, S-H-E-N-T, which is women in ENT. I actually really like that portmanteau. That's nice. Yeah.
All right, so the next question we have, what are your thoughts about selecting a username for accounts that you use for professional posts? I could take that one. I think that, when we look at kind of promoting your online kind of persona, especially from the professional aspect, I strongly encourage, people who are starting with Twitter to use their full name as they see it kind of like on their, maybe the Pitt DGIM website or wherever they would find it, and include MD so that when people are searching for you, because inevitably they probably will be in some facet, your professional website from your institution will come up, but also your social media account also. And they will be coupled in web browsers. So, I personally would say, first and last name, comma, MD, comma, whatever else agrees, things like that is more beneficial than the nickname you were called in high school. And so you're much more findable. And especially if you're promoting content on a professional standpoint from education or promotion of, residents or whatever that may be, it's much easier to find. Another question is, Twitter is so fast. How can we keep up? I feel bad that I don't respond to every post, which seems like a full-time job.
Yeah, that's a good question. It's really easy to feel like that. The short answer is please don't feel bad. This is, and something that's also worth emphasizing, this is purely extracurricular activity. Your job as a physician, everything else that you do, teaching your residents, your medical students, your fellows, any trainees in person is really what counts and really what people value. So everything else that people do, it seems like they put a lot of time and energy into that. That's true. They are putting a lot of time and energy into it. That's their own choice. So every little thing that comes up, just kind of let it wash over you. And that's honestly why things like pictures are important on Twitter, because they draw the eye of people while giving lots of information out. So don't feel bad about how fast everything on Twitter moves, on social media moves. Just choose where you want to spend your energy and what you view. And if you miss something, that's okay. Something similar will probably come up a week from now or an hour from now, honestly.
Okay, I think we're rolling up on our time limit here, so I will move to the CME code. And if there are any other questions, I'm sure that we can take them or try to take them offline. I don't know if you guys have anything else to add before we end.
No, sounds good to me.
Yeah.
All right.
Thanks for coming, everyone.
start the game again?
Good afternoon. I'm Dr. J.B. McGee, and welcome to my dining room. I'm the Director of the Lab for Education Technology at the School of Medicine, also Assistant Dean for Medical Education Technology. And I appreciate the opportunity to share with you some of what we have learned since the pandemic started, and some of which we were using before, but now using online learning and remote learning technology full time. We will have a chance at the end to answer some questions, and feel free to post them in the chat area on the YouTube site. I'm going to go ahead and get into the presentation. I want to just mention I have no conflicts of interest. I want to also thank the Academy of Medical Educators for this invitation. I've been a long-term proponent of asynchronous and technology-based education, and am thrilled that we are all learning online. Maybe not everybody is as thrilled as I am, but I suspect that some form of online teaching is going to be with us for a long time. So hopefully what I have to share with you today will help you with some of that, even when we get back in the classroom. So let's look back at 2019. And this is kind of what it looked like, at least at some of my lectures at the University of Pittsburgh. This is before we were thrust into online learning, and lecture format was still a big part of what we delivered. Of course, they were recorded and students listened to them at home on their own. This particular class is actually one of my lectures in digestion and nutrition. Thankfully, a few more students wandered in, but it's always a little disturbing to look out into the audience and see a whole bunch of empty seats. Although the one seat that was filled, it was with somebody who seemed quite happy to be there. But we know that students before the pandemic were watching our lecture videos at 2 and 3 times speed on their own schedule, and frankly, I don't blame them. So engaging students online is not going to be any easier than it was trying to engage them in the lecture hall. In fact, it's probably going to be a little bit harder. Anyone who has kids at home knows what I'm talking about, and that Zoom doesn't make class or meetings any more interesting. Makes them a little easier to get to, and it has its advantages, but it's not solving all our problems. So today I'm going to try and inspire you and share with you a few tools for maybe making your online presentations, your lectures, and your coursework a little bit more engaging and less reliant on lecture-based delivery. We'll get into producing video, we'll get into whiteboards a little bit, also using some of the polling software that's out there, and then share with you some tips and tricks from me and from others who have been doing this for a while. Lastly, I'll finish up by giving you some links and references where you can go and get a lot more assistance than we're able to cover today. So let's start with lectures. I mean, lectures aren't going away. In some form, they'll be with us for probably forever. Currently, we're using Zoom and Teams to give most of our lectures and for small group sessions. But we also have the choice of giving live pre-recorded presentations. And at least here at Pitt, what we're using is Panopto for that. What I won't be covering today, though, is the basics of Zoom and how to log in and how to get into meetings like this. All of us have probably had more than enough practice with Zoom with all of our faculty meetings and other events. What I do want to share with you is going beyond Zoom. Not that Zoom doesn't have its advantages. I promise you I'm wearing pants today, but I am wearing slippers since I'm at home. The advantage of Zoom, as we hear from our faculty, is that it's easy. I mean, we know how to use it. It's familiar. You can share it with just about anyone. A link is really all it requires, and don't even have to download the app. You can access it through a browser. So the accessibility and the ease of use is what's made it as popular as it is. And it's familiar. We're used to lecturing with PowerPoint to an audience, but as I showed earlier, I'm not sure that's always the most effective approach. The other thing that makes it easy at Pitt, at least, is that it's automatically recorded to Panopto, and students can go back and relook at them just like they did the lectures last year. There are some disadvantages. It is being phased out at UPMC. They're not allowing faculty and staff to have the Zoom application on the hospital computers, which from security standpoint is probably a good idea. And even Pitt is cracking down a little bit on security. So starting on September 28th, just a few days, a password will be required with any Zoom meeting that you set up or the use of a waiting room. We're recommending for the lectures to the medical students that you go with the password approach. So why bother pre-recording if it's so easy to use Zoom? Well, there's a good bit of evidence to show that it's more effective educationally, that students get more out of it, maybe because it's better quality, the audio, the video is all pre-recorded at a much higher resolution and much higher quality. And also, if you're doing it right, you tend to script your presentations. And scripting a presentation has also been shown to have a more educational value and contain far fewer errors. Another nice thing you can do with pre-recorded videos is break it up into chunks. It's difficult to sit there and listen to a presentation, even one like this, for an entire hour without losing your concentration, without being distracted. Breaking it up into smaller chunks, and the current recommendation is nothing more than 15 minutes of video before having something to interrupt it. But with video, then you can throw in a quiz or an activity, pause or maybe a review, so that your learner doesn't get too bored and doesn't get too bogged down. And the other nice thing about it is that, not everybody has fast internet access. I'm sure all of you have experienced images like on the screen here where things started to break up because of problems with either your home internet or bandwidth in general. So what you do get from video is nice, high quality that is also portable. You don't have to be connected to the internet to interact with it. So I mentioned Panopto. That is the technology that we're recommending to most people that are working with the medical students and here at Pitt. It does take a little effort. It's a little bit more of a hurdle than Zoom is to start using, but you can go to the website and download the software. There's some very good tutorials at that same Pitt website. And with a little bit of practice and maybe some help from friends and neighbors, you can get going on it too. It does give you some advantages though. You can get the lighting right. You can get the sound right. You can practice the dialogue, and scripted dialogue is going to be more accurate. And of course, you have unlimited do-overs. What I hear from a lot of faculty that are new at using Panopto is that they end up recording the same section over and over to get it just right. It's not that they're not getting it right, but for the OCD types, it's an opportunity to refine your presentation skills and create something that has some lasting value. And beyond using it this year and for lectures and for the current courses, you may be able to use that same video over and over again for years, and doing it at a high quality will pay off in the long run. This is what the Pitt Panopto website looks like, and don't worry, at the end of this presentation, we're going to share with you in the chat the links. If Franklin Pfeffer's on with me today, and he's our primary support person in the Lab for Education Technology, and he's going to help out with getting some of the links online. And if that doesn't work through YouTube, we'll provide them for you separately. But you go to the Pitt website, and if you just put in Panopto PIT, you'll be directed to this site. You will have to log in. You have to have PIT credentials in order to access this. And then once you do, the first step you want to take is to download the Panopto application. This will install on your computer, so you can end up using it either in your office computer or your home computer or both. You can't install something like this on a hospital computer, obviously. And you'll see there's a number of options here, and but the end result, if used in even the most basic way, looks something like this. And I apologize to Cynthia Lance Jones. I didn't warn her that she'd be part of my presentation today, but she really has become probably the most prolific Panopto user in the school, and that she participates in many different courses and is a master educator herself, and has used this in creative ways to create what goes a little beyond Zoom. So you've got not only the slides that she's presenting, but an image of her and on video, and then below the slides, there's navigation tools to either speed up the video or find a specific slide. So again, a little bit better than just recording something directly on Zoom as a live lecture, and she can refine this and get the duration just right and the quality just right. Well, I wanted to share with you, if you haven't already heard of him, a name and a gentleman called Michael Wesch. He is somebody who's a bit of a YouTube superstar in the education realm, and has produced a number of YouTube videos about education, initially about millennials, which is when I started following him a while back. And now he is doing work related to teaching online. And he's a professor just like the rest of us. And he's an anthropology professor at the University of Kansas. And he started doing online teaching and producing videos because, frankly, students were pretty bored with cultural anthropology, and he had to find ways of keeping them engaged and entertaining the students a little bit along the way. So there's a number of videos, again, that we'll share the links for, and that are, I think, are really worth watching. These are some of his recommendations for online teaching in general. Keep it very simple. Be sure to communicate with them in the beginning with some sort of group discussion or a group session, so they get to know you and you get to know them. Explain to the students why you're doing things in the way you are and why the curriculum is laid out the way it is. He recommended, maybe worked with smaller classes, have students create their own video introductions and post them on the course webpage, so that people start to get to know each other. And in particular, this year, the first year students really haven't had much of a chance to bond and get together face to face. This could be a technique that helps bridge some of that. He does weekly overviews on Friday afternoon for his course. This could also be a quiz or maybe a video with the answers to the quiz and some explanations and answering student questions, but some sort of wrap up at the end of the week where you get, and the students get a concise but effective overview of what really important happened that week. And then responding and providing feedback always is important for any type of education. So I just mentioned that doing video in Panopto has some advantages, and I wanted us to kind of spend a little bit of time just looking at that and what does it entail, and maybe some tips on how to do it a little bit better or maybe easier. So it's surprising how easy it is to produce video, and the students who were and residents who were on the previous workshop probably think that this is something that just comes naturally. But for those of us in my generation, producing your own videos was a pretty big deal, not something that for the average educator. But now with mobile phones having fantastic cameras on them and the ability to edit even on your mobile phone, and if you get one of these handheld Steadicam type devices, you can produce some really professional looking stuff. And it's surprising what, with a little courage and a little effort, what you can do. Now we're currently recommending that you use Panopto to edit your videos and post them online. That would just be easier if you're using them to teach in our curriculum. But if you're using it for a residency program or others, you may have other sites that you want to post your videos to. If you are producing video for the core curriculum, though, I'd warn you that while social media and YouTube have a lot of value, as we just heard, the school and the university doesn't want you posting core curriculum there unless it's a special situation. And if you want to get it into Navigator, which is our software platform for the curriculum, just let us know. And LabEDU at pitt.edu gets all your questions answered and all the assistance that you need to connect with the online curriculum. So back to Michael Wesch for a second. He's got some advice on teaching with video and techniques. Again, go to YouTube and he's got some well-produced videos there. But he encourages you to put yourself on the camera. I mean, students are there to hear what you have to say. They care about what you, the professor, the expert, knows and what you think is important. But realize that they probably don't want you on there the whole time. So going back and forth between either others contributing to your videos or using existing video or even, old-fashioned PowerPoint slides. But then jumping back in and showing your face intermittently, and especially at the end to kind of summarize and wrap things up, has a lot of value. It also encourages you to kind of get out in the world, get that cell phone of yours and, open up the door and walk outside and, film some things that relate to what you're trying to teach. Maybe it's in the research lab, maybe it's in a clinical setting. Be conscious of patient privacy, but there's a lot of situations where students can really connect and understand what you're talking about by seeing the real thing on video. And of course, patient interviews and things like that are tremendously valuable to students, especially novice students. Another idea that he shared was have students do a video project, maybe in small groups. They come together to, answer some specific questions in short videos. If I ask the students in my GI course to maybe make a video about why is stool brown, I imagine that we'll get some creative responses and creative videos around that question. And don't worry about too much about borrowing video from others within fair use guidelines. And if it's just used within the confines of the school for your students, there's a lot out there that you can borrow that's maybe copyright, but for educational purposes will be adequate. And then there's a lot of free video websites too. Again, we'll share some of those links. So if you're producing video, that I wanted to make a point that good audio really matters. In fact, it matters more than good video. Lots of studies around, user satisfaction with teaching online and videos, and audio always comes out number one. And it's not that hard to do. Here I've got a picture of 4 examples of ways to get good quality audio, and not just in a pre-recorded video, but for your Zoom calls and other video-based interactions. You can use any of the earbuds that have a microphone attached to them. Using a lavalier mic is especially good quality. And of course, you can do like on the lower right-hand corner and have a professional quality mic and headphones and such, and if you really want to get serious about it. This is what I use though, and this is what I think is really improved the quality of my life. Now stuck at home with telemedicine a good part of the day, with lecturing and meetings a good part of the day, all being done online. These little wireless earbuds have enabled me to kind of branch out and get away from the camera when I'm not on screen, and take out the garbage or prepare dinner, and nobody needs to know that I'm walking around with them in my ear. But be sure to turn your video off. That always could create some embarrassing situations. And you don't have to buy Apple products. That's just happened to be what I use. And then after you got your audio game down, look into how you would get maybe a little bit better video than just relying on your laptop webcam, which, if it's a new laptop, it's a pretty good quality webcam. I've got a relatively new monitor in front of me right now. I'm using the webcam that's built into that, and that is more than adequate and in pretty good quality. But be aware of things like lighting. All of us have been in meetings where our colleagues have looked like this on the screen, and a little attention to making sure that the light is in front of you and not behind you can go a long way and make it a more pleasant experience for the others watching you. Also, elevating your laptop up a little bit so that you're not looking down all the time. It's more flattering and also ergonomically more comfortable. And it doesn't have to be a dedicated stand like this. You could just stack up some books. Nobody's going to know the difference. And get the webcam that's on your laptop or computer at more or less eye level. If you don't want to do that, you can even use just your iPhone on a cheapo tripod like this. And connecting up a phone with some wireless earbuds that have a microphone on them, you've got a pretty good quality little video audio production system together. It's portable and easy, and you can go anywhere in your house with it. And surprisingly, the quality is pretty good, especially with newer phones. Or you can get kind of serious about it. Here I've added a light, which goes a long way. It's just a little portable battery-powered light that shines in my face on dark days, which we'll have some more of those in the future. And then I've co-opted my handheld camera or a point-and-shoot camera and plug that into the computer and using that as a webcam. I especially like this picture. This is Michael Wesch, and what he's done here is take his phone and taped it with duct tape to the window, and he'd taken his script and duct taped that to the window, and picked a window in a really bright sunny spot, so it looks like professional high quality lighting on him. Nobody knows that he's standing right in front of a window. In fact, if you looked at his video that he made from this, you'd think he was in a big room in a professional studio. But sunlight better than any studio light that you can buy, and it really quite flattering and pretty cheap setup there. So remember, audio is number one. A few other little tips. Be sure and emote. I'm probably not doing a great job of that either right now, but you do have to talk a little bit more loudly or a little more emphatically on video in order to look good. Finish your sentences cleanly. Other little tips is try and use landscape mode. Most people are watching these in landscape mode, and while you may not be used to doing that with your cell phone, turn it sideways and avoid compressing your video vertically. Use large text, keep it really simple, turn on closed captioning, and be sure to look at the camera. I forget to do it all the time, but you tend to look down or at the screen or at some, maybe your cell phone or on the table. Look up at the camera. It's always going to make you look better. Then if you want to get really serious, and I have to admit, I think it's being stuck at home and doing telemedicine all day and doing all the teaching online and recording online, but this is what my my dining room has turned into. We've it's nice that it's being used, though. The formal dining room was pretty lonely previously. I had to dust things off, and here I've got all kinds of things to make it a little bit easier, improve the quality a little bit. A big monitor really helps. I've got my iPhone mounted above the monitor so I can do telemedicine interactions with patients and look at their record at the same time on the big screen. The LED light panel, I've got that shining out over here right now, and I've got my DJ microphone that gives me nice quality, and other things like AirPods and headphones So you don't have to go this far. We are building a studio in Scaife Hall that has all these things and more, has a dedicated computer and dedicated space, and especially important, a space that's quiet, a space that faculty can go to record lectures and to engage in online teaching, that they don't have to worry about the kids running around or dogs and pets interrupting their presentation, and has all the equipment and software that you could use. I wanted to introduce you to a few more techniques that kind of take you beyond the basic lecture presentation. Some of you may have already used this, but whiteboards in Zoom are super easy to use. It's just like sharing a screen. You select the share screen button at the bottom and then select the whiteboard, either double click on the whiteboard icon or click the share. Now you do have to have permission. So you have to be a host or co-host, or the host has to turn on allow sharing for everybody. But that's, none of that's hard to do. And the whiteboard can go a long way towards interacting and with students and working with them. So there's an option on the shared screen button, and just that little tiny arrow to the right of it will pull up some options to let multiple participants share simultaneously. So you can engage students in contributing to an image or some notation, small group learning that should come in really valuable. And the other option is to allow annotation. Now, what is a little tricky is if you're the participant or a student out in the audience, you can't start writing on a shared whiteboard until you click the View Options button up near at the top while a screen is being shared, and then click Annotation. It took me 15 minutes to find that option when I first started using it. But remember too, annotation works with just about anything that you can share on Zoom. So you can add arrows to images that you share. You can circle things on PowerPoint while you're presenting. It's really got a lot of options, and just clicking that annotate button that you'll see up near the top of the screen or wherever you have your menu bar. One of the questions I've gotten from faculty is, and one thing that is disturbing, and I'm suffering from it right now, is that the question of, is anybody watching me? I'll look up on the YouTube. I've got a separate monitor with the YouTube feed. Looks like there's 70 people online. That's encouraging. But it's hard to know who's there and whether the students are falling asleep or anybody's out there. One little trick is to just throw in a pop quiz and that you made using a Zoom poll. And that'll be a good way to know who's there and have everybody answer in the chat. And right away you'll see names and responses, and you'll know who's watching and who isn't. It's also a good way to take attendance. You could use the other things like Poll Everywhere and quizzes in PowerPoint to also kind of keep the students awake and interacting. And then finally, if you're really curious about how popular you are or whether anybody's watching or engaging live or afterwards, the Lab for Education Technology can generate some reports for you. So this is what a Zoom report looks like. It says, what the event was, when it occurred, but and more importantly, how many participants there were for each of the online events. This is what a Panopto report looks like. Gives you a little bit fancier overview of what's happening online. And this is the actual data. Looks like the medical anatomy in the first year is taking up most of the Panopto time, which makes sense. And then I also want to encourage you to use audience response systems. We've got quite a few different ones to choose from. You can use the one in Zoom, which is basically their polling option. Poll Everywhere, if you're not familiar with it, is dedicated software that's really quite fancy, and it can do all kinds of polling and surveys and quizzes. And then probably the easiest way to use that is to roll that into PowerPoint and embed the Your Poll Everywhere survey within your presentation. Now the OMED office helps out with that. We have a license to Poll Everywhere, and they can help you get that integrated into your PowerPoint slides. The Zoom polls, be aware that you got to plan ahead of time and create the questions. Actually, I was going to have a poll in the middle of this presentation today, but found out that it's being live streamed on YouTube, so that wasn't going to work. But you can preload your polls and ask for interaction. And then, just if you want something kind of quick and dirty, using chat and Zoom and Teams to ask questions works pretty well, and you can do those on the fly. So a few final tips about teaching online and teaching with video and teaching with technology in general. When you're online and doing something live, it really helps to have somebody else working with you. I've got, Franklin in the corner of my eye, and I can see his face and see his interactions, which otherwise I can't see any of you because this is on YouTube. But otherwise, it's a little hard to broadcast to a blank screen. Also, I told Franklin to wave his hands and make gesticulations if I'm doing anything wrong or inappropriate, or if we lose the signal or something, he can text me and let me know that everything's okay. Another thing I do with important presentations like this one is that I have an iPad up here mounted above my screen that I can see the YouTube feed in my peripheral vision. That'll alert me if something goes down or goes terribly wrong. Some of the other things that just little tips that I didn't want you to miss today. The mute all button, which is in a drop down on the Zoom software, can be really useful if you've got 150 people in a meeting and somebody somewhere is making all kinds of noise or eating their lunch loudly. You can shut everyone else off and quieten down your presentation. And then don't be hesitant to use PowerPoint. It still is a really useful tool. It's gotten better than ever, and a lot of us are pretty familiar with it. You can do all kinds of fancy animation. It's got some nice icons that maybe you're seeing during this presentation that you can pop into your presentations and make them a little more visually appealing. We're encouraging faculty to set up regular office hours. So a time during the day, maybe daily or on specific days of the week, where you or one of your faculty members will be on a Zoom meeting and available for students to just drop in, knock on the virtual door, and interact and ask questions and have a little bit more personal interaction than you're able to have when you're lecturing to large numbers, or if you're delivering everything by pre-recorded videos. You kind of miss that one-on-one interaction and the questions that would come up at the end of a lecture. This way it kind of fills in for that. And then all the usual things that make for good education, being consistent and repeating things that are important and underscoring and providing the students feedback. It kind of comes naturally when we're teaching live because we've been doing it for so many years, but reminding yourself to do that when it's virtual. So the end of the week overview or the end of the week feedback, or if a student does ask you a question, either through email or through the Navigator course director's blog, maybe provide a video answer at the end of the week that the students can look at and be a little bit more engaging and helps them kind of guide their studying and guide the focus within the course. And one last thing that catches a lot of people is that when you sign off of a Zoom meeting or such, it freezes your image. You won't see it, but all the other participants will see it. And if you're frowning or looking away, just give it a nice little smile at the end and leave them with a better last impression. So let me just share with you some places to go for further help, because this clearly just touched on these topics. And if you decide to dive into some of these techniques, there's lots of resources available to you. This is the Zoom Help Center. It's available to anyone. It's their commercial help center. It's fantastic. Almost everything in this help center is done in video. They're short videos. They're frankly good examples of how to do an online educational video. And it covers just about every subject you can imagine. Another terrific resource, as much as MyLab and the OMED office are available and right there for you to help you with your learning and teaching, the University Center for Teaching and Learning has expanded tremendously and is a big staff ready and waiting to help you with your course materials. Now, they're mainly focused on the lower campus, as you would expect, but they're open to providing assistance to the medical school, and they have tons of materials online at teaching.pitt.edu and provide one-on-one consultation. They have video services, audio services, production services, and I encourage you to take advantage of that. Some links for some local contacts. I think just giving those to you after the session makes more sense, but be aware that there are people here at the school that are available to help you with all of these topics and more. And also consider watching some of Michael Wesch's videos. So let me finish up there. I didn't want to keep you too long on a Friday afternoon and wanted to leave plenty of time for some questions. Where there's a delay in questions because of YouTube. Did want to let you know that this is being recorded. Unless I'm missing something, I'm not seeing much in the YouTube chat feed. Giving it a little time because of the 30-second delay that's built into this system. But I do want you to
Okay, we've got a question now.
Oh, good. Thank you.
All
Franklin.
Right. Question here. If someone wanted to replicate your excellent setup that you have at home, which one or two extras would you say are most important to have?
That's a really good question. So first and foremost, microphone, but just using the earpods work. It's got a pretty decent microphone on there. You don't necessarily have to get something like this. And then the next one is lighting. You'd be surprised how much of a difference that makes, and it can help compensate for days where you don't have good sunshine. So I think in that order, a microphone of some kind, and then lighting in your space can really improve the overall quality, because the extra lighting doesn't just make your face tone look more normal. More light makes it easier for these systems and these cameras to pick up the image and record it.
All right, we have a couple more questions here. Next one is, with narrated PowerPoint videos, do you recommend including a video of the speaker's talking head?
So another question from YouTube, and Franklin shared with me. I don't know if you can hear him or not. I think so. But the question was, do you recommend having the talking head? You'll notice that I kept my head on through this session, but if you can, going back and forth, I think is better. I didn't want to make things too complicated for myself, but I'm using some software that allows me to switch, so I can switch to just slides, or just me, or slides and me. Problem is, I can't think and talk and click at the same time too well, so I tend to kind of keep it with just on the side. But bookending your presentation with video of yourself and video kind of summarizing things and introducing things at the front end makes for a nice quality presentation. At least have a little video at the beginning. Now I lost Franklin. Franklin, can you still hear me? So for some reason, I can't hear anybody. I can't hear him, but that's okay. So the question says, can you talk more about how to use the polling/quiz in recorded education sessions? Well, if it's pre-recorded and you don't have an audience live, it's a little hard to take a poll. But if you're pre-recording, what I would do would be, break your recording up into small segments and then stop and have a quiz. That quiz may be separate software online, or you could just post the quiz as part of your video recording. The advantage of, say, putting it into Navigator, if you're using that, or putting it into Poll Everywhere, is that you can pull the data from that survey or quiz, and it can tell you a lot about whether what you're teaching is being effective, and tell you a lot about what the students are thinking about. You can use to adjust your presentations in the future and give feedback to the students.
Sorry, I think my microphone went out for a second there. Can you hear me now?
I can.
Okay, we have another question here. How do you find a balance between reading off your slides and not providing enough information in the PowerPoint, and having the students spend too much time writing what you say?
That's a good question. You probably were wondering how much I'm reading off my slides, and even now, because I'm not a fan of reading off of slides, not a fan of having a lot of text on the slide. The images are there to enhance what you're talking about. But on the other hand, if the students are watching this asynchronously, then having some sort of notes can go a long way, and them not having to kind of write everything down. Now, if you're teaching in the years 1 and 2 medical school curriculum, theoretically, the syllabus that you provide should have all the text that the students need. Theoretically, it should follow the sequence of your slides and presentation. If I had to make a choice, I would have less text and not read off the screen, and teach less and convey less information so that it is comprehended and absorbed more, and then provide additional reading materials or maybe a document with more details if need be. But I think we're all guilty of trying to pack too much into our slides, and especially too much text. And someone is recommending to provide a handout in a download, and that goes a long way. And telling the students up front that there will be a handout that has everything that I'm going to talk about. Hopefully they don't tune out at that moment, but letting them know that they don't need to take notes constantly while you're talking. All right, any other questions? So here's a recommendation. Someone's saying share a presenter version of their slides along with the text that goes along with the presenter's notes. I think that's a terrific idea. That way the students have the text and the notes aligned with the images that were presented. So someone says, I have some students complain that the videos take too long because they're writing down notes. I don't know. It seems like our students complain that the videos are too long because we talk too slowly. Yeah, I think doing the note taking as a separate exercise, whether it's downloading a document or providing it in the syllabus, and to have that ahead of time makes a lot of sense too. So another reason to focus your presentation on the presentation. It really should be about emphasizing the major points, explaining things that are difficult to understand, but not necessarily covering the topic in completely. That can be done written, and people can read a lot faster than you can talk. All right. Well, I think we may be running out of questions. I really do appreciate you guys taking some time on a Friday afternoon, and especially appreciate the Academy of Medical Educators for allowing me to share this with you. I did want to have a poll at the end of this presentation that was going to ask how many of you expect to be delivering your lectures and your course materials online a year from now. I certainly hope that we're back together face to face a lot more a year from now, but also I hope that teaching online and teaching using pre-recorded materials and some of the technologies that we've been forced into, hope those persist. So you can tell me through the comments whether you think we'll be doing these working online at least somewhat a year from now.
And we do have another question in chat. If you think there's time, someone's asking if you can provide any other suggestions on resources such as VP-Sim or anything else.
Yeah, so if you mentioned VP-Sim, that's another software application that we developed in my lab, and it's used to develop your own on-screen simulations of patient cases, but also can be used to create other educational interactive scenarios. There's a couple other software applications out there, one called Articulate, another one's called Captivate, that do similar things where you create online learning modules that combine video and images and quizzes in a more sophisticated way than just recording a lecture. Those are nice tools. I believe some of that's available through the free downloadable software from Pitt if you're a faculty member. Also, make an appointment with us and we can sit down with you in kind of a consultation and discuss, what tools are out there and most importantly, discuss what your goals are for teaching and what outcomes you're trying to achieve. And that'll help guide which technologies might be best to meet those needs. Let's see, Paul Frampus says, hope we use this time of disruption to optimize all of our teaching. Yeah, it is a good opportunity. I'm preparing for the digestion and nutrition course and working on some pre-recorded videos and recognizing that my slides that I've been using for a few years could have been better, and that my presentation of the information could be better organized. And this is an opportunity to kind of step back and redo some of these things. And yeah, we're being forced into it, but it is probably time for a little revamp. And I also, warn you with, I don't know how much the word is getting out, but the curriculum is going to be reworked and renewed over the next few years. And I think you're going to see a lot more asynchronous learning, a lot more online activities. And so the work you do now in creating materials is going to pay off in the future. Let's see. Yeah, I think one of the comments I think means that this time with the pandemic and being forced online is going to teach us a lot about what is the right amount of online teaching and what are the right things to do with these technologies, and what can it not do. I'm anxious to see some of the research that's going to come out of this. It's an unusual experiment, but one that's going to teach us a lot that we never would have understood otherwise. The other group that you can learn a lot from about what's the right thing to do online and what isn't is your children. They are being subjected to this, and I imagine there's some very good examples of how to teach online and some very bad examples of how to teach online. And that particular group is getting bombarded with more online teaching than ever before. And we're going to learn a lot about what's effective and what's not effective from that cohort. All right. I think we'll kind of wrap it up here. Not quite at the end of our time, but want to, again, thank everyone for hanging in there. We've still got a good group of people hanging on and listening. And thank all the technical people for their help. It made this a lot easier than I expected. Thank Franklin. In fact, Franklin's your main go-to person in the lab, so this won't be the last time that you hear from him. And again, our door is open and our communication is open. So don't hesitate to reach out to us for help with your course, and and I'm sure we'll learn a lot from you as this unusual era continues.
Thanks, JB. That was great.
You're welcome.
A couple just final comments for everybody. We just want to thank our speakers, our keynote speaker, Dr. Cutrer, and our workshop speakers, our social media experts, Drs. Simonson, Coley, and McQuaid, and our in-house tech expert, Dr. McGee. Couple housekeeping things. All the presentations are recorded and are available on the AME website. In case you missed the CME numbers, they're available for 2 days at the AME website. And everybody who registered will get a feedback survey. If you're not registered, you can still do the survey at the AME website. And everybody, thanks for hanging in there. This was obviously new ground we were treading, and we appreciate your attendance.